Done, ma'am. Is my slide visible?
Yes, one of your slide is visible.
Yes. Okay. So, good evening, delegate faculties and the guest present over here. I, Nitesh Srivastava, on behalf of Corona Remedies Limited, welcome you all in Happy Learning Masterclass series. Now, I would like to hand over this session to Dr. Monica for the program conduction. Over to you, ma'am.
Dr. Monica, we can't hear you. Monica? You are not audible.
Ma'am, you are not audible.
Yeah, can you hear me now?
Yes. Well,
Yes, ma'am.
Yeah. A very warm welcome to all the esteemed faculty members and the delegates who have joined us today for the 240th episode of the Happy Learning Masterclass webinar series. This program focuses on the theme ultrasound in OBGY, and we have esteemed faculty members who are stalwarts in their respective fields: Dr. Sonal Panchal, Dr. Vandana Bansal, Dr. Sujit Konkar, Dr. Jaya, and Dr. MC Patel sir will be speaking about various issues in ultrasound. Today, let's evoke the blessings of Lord Almighty before we start this program. Can we have the inauguration slide, Nitish?
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति शान्तिः.
Thank you so much. It is my proud privilege to welcome Dr. MC Patel sir, the program director of this series, who has been constantly striving for this series since the time of COVID. Sir had started the series with the vision of getting academicians together and pass knowledge through the tough times in COVID. Sir has also been the past vice president of the FOXI. Sir has also been the chairperson of the Medical Legal and Ethics Committee. He has been the past president of the Ahmedabad OBGY Society and IMA Ahmedabad. Sir is very passionate about teaching, and he is your presidential candidate for the year 2026. So we request all the societies to please nominate for him as the presidential candidate, and please vote in August. Sir, over to you for your words of wisdom.
Thank you, Monica. It gives me immense pleasure to welcome you all on 240th episode of Happy Learning Masterclass web series. As rightly mentioned, in era of COVID-19, where physical meetings were not possible, I started this series with very few friends. And at that time, intention was to meet our Foxian friend and to say hello, to ask for their health in COVID. And we were discussing focus topic, and ultimate goal was to be helpful to our Foxian friends in their day-to-day practice and to check maternal mortality and infant mortality. But with love and affection of all, we still continued with this series, and today is 240th episode of Happy Learning Masterclass. So every time we discuss focus topics, as for example, today we are going to discuss ultrasound examination in OBGYN practice. And we have invited stalwarts in field of ultrasonography. I welcome Dr. Sonal Panchal madam. She is master in sonography as far as gynec sonography, particularly infertility sonography is concerned. And she is popular teacher, I would say. There are so many trainee. They ask for training from her only in Dr. Nagori Institution, where Dr. Sonal Panchali, Chief Sonologist. I also welcome Dr. Jaya Chawla, Madam. She has stayed with me many times in so many of CMEs and in webinars also. And she is going to discuss very interesting topic of first trimester screening and why it is very much important. If we picked any anomaly or any abnormality in first trimester, it will be very easy for us to counsel patient and manage that very pregnancy in further. It will be very much useful. I also welcome one more legend in ultrasonography, Vandana Bansal Madam from Mumbai, and she is going to discuss mid-trimester anomaly detection, what is next. And it is also very important area because in mid-trimester, when some anomaly is detected and to confirm it, many times we have to take little time to offer some other investigation, and many a time a limit for termination of pregnancy is crossed. And in this type of situation, it becomes very difficult for us also to guide our patient. So if it is early picked up, then it will be always beneficial to the patient. One more legend in sonography field, Dr. Sujit Konkar, and he's going to discuss color Doppler in pregnancy. And it is also one more area and very important area as far as investigation is concerned. And at the time of monitoring that very pregnancy, color Doppler is the key as far as fetal's well-being is concerned. I also welcome one more legend from South, from Kerala, Dr. Suma Vishnu, and she is going to discuss Leica abnormalities and associated anomalies. Suma is also very much interested in this sonography and fetal medicine, and she has also said our stage in Happy Learning Masterclass many times as a faculty, and she is from Wayanad. So welcome, Suma, and I will be dealing with sonography and law. So this is the topics today to be discussed. I also welcome my own team, Dr. Monica Umardan from Solapur. She is convener in this series since long. Dr. Monica Gupta from Alwar, Dr. Deepika Logani from Delhi, Dr. Nivedita Datta from Bokaro, Dr. Satabdi from Siliguri, and Dr. Megha from Kalaburgi. And they all are coordinator in this series. And due to all of them, we can come well in time to every Tuesday as far as our Happy Learnings episodes are concerned. So welcome all team members and welcome all the delegates who have joined this webinar. So without wasting much of your time, thank you very much. Monica.
Thank you, sir. Sir, should we start with the academic session?
Yes.
Our first speaker is Sonal Panchal.
Madam,
Ma'am.
to
Please
please.
start.
Hello.
Hmm.
Ma'am, can you please start the first session?
Yes, I have already started. She is going to speak on ultrasound in infertility. And she's a consultant at Dr. Nagori Institute for Infertility and IVF at Ahmedabad. She has done PhD in ultrasound. She's a master ultrasound in OBGYN at prestigious Ian Donald Inter-University School of Medical Ultrasound. She's a professor in Durnovic International University, National Academic Director at Ian Donald School of India, and she's a director of Center of Excellence in Ian Donald Inter-University School of Medical Ultrasound, Ahmedabad, India. And she's in the advisory board for International Journal of Infertility and Fetal Medicine of JP Publications. She's a reviewer of Journal of Human Reproductive Science. She has published 45 papers in national and international journals and delivered more than 800 lectures, and she has contributed and authored several books and written more than 120 chapters. She's an expert in 3D, 4D ultrasound, gynae ultrasound, and in the infertility ultrasound also. And I think she's the best person who can do the justice with this topic. Over to you, madam, for your talk.
Thank you very much, Dr. Monica, for those very, very kind words. And since there are just 20 minutes and the topic is really wide, I'm just going to right away start with the presentation. Thank you very much to Dr. MC Patel, sir, and the entire team. And let's start with the topic. Ultrasound and infertility. If we say ultrasound and infertility, where all we can use ultrasound for in the practice of infertility? We can use it to decide what should be the stimulation protocol. If we decide to give them gonadotropins, what dose of gonadotropins daily should be given to a particular patient? So individualization, the stimulation protocols. When to give a trigger, what should be given as a trigger? If IUI is to be done, when and how many? Do we need to change any treatment strategy? If the patient doesn't conceive, everything practically can be decided by doing ultrasound, starting with deciding the stimulation protocols. Unlike what we all have been doing since many years, using only the ovarian reserve parameters like FSH, AMH, age, BMI, and AFC to decide the stimulation protocol, it is very, very important to understand that it is not just the ovarian reserve which decides what should be the gonadotropin dose. It is also response of the ovary, which is important. Now, what do we mean by this response of the ovary? The response of the ovary is the amount of push, the dose of gonadotropin daily that is required by the patient to produce those required or those expected number of follicles is what is called response. And this is dependent on the ovarian stromal blood supply. And we'll go through it in a little while. Let us start first with the reserve parameters. And as we know, the reserve parameters are the antral follicle count and the ovarian volume. We all know how to count antral follicles, but it is very important that we all be very systematic on it. Remember, locate the ovary and then span the probe so that you are not seeing the ovary at all. Then come back spanning across the entire ovary till you lose the vision of the ovary on the opposite end, and during this, you would eyeball and count the number of antral follicles. Remember, when you do this, you are not going to rotate the probe, you are not going to span the probe. It is to be measured in the entire ovary. There are some studies which are done on counting the antral follicles on a single plane, but that is not as accurate as it would be with the assessment of the antral follicle counts in the entire ovary. So remember, antral follicles are to be counted in the entire ovary, not in a single plane. If the number of follicles are up to 12 to 15, whether you count it like this by a 2D ultrasound or you do it by 3D ultrasound, both are equally reliable. But when there are truly multiple antral follicles, like in PCO patients, at times more than 30 per ovary, that is when the chances of human error is very high. And it is in these cases that one should select the sophisticated 3D softwares like Sono AVC, which color codes every follicle and therefore counts them correctly. Of course, a bit of post-processing may be required in this, but still it takes lesser time not only to count the follicles correctly, but also to calculate their correct size. Now, it is important here to understand that the Sono AVC is chiefly required when you are going to do an IVF. Because when you do an IVF, that is when the number of follicles that will grow to maturity with the standard doses of stimulation are 60% of the total antral follicles. And there you are expecting more follicles in IVF. And therefore, it is important to know the exact number of follicles, but when it is IUI cycle, you actually do not require the sophisticated 3D methods because your ultimate aim is to just produce 2, 3, 4 follicles, not more than that. And that is when it is sufficient to know approximate number. And therefore, for the routine IUI cycles, to count or to assess the ovarian reserve, you do not require to do do not require to use Sono AVC. But these scans must be done on day 2 or 3 of the cycle. This is called baseline because at this stage, not only the ovarian steroids, but also the FSH, LH are at their lowermost level. And this is the silent ovary. And that is when you measure the blood flow, measure the number of antral follicles and the size of the ovary. About the size of the ovary, I don't think we need to discuss much. We all know that we are going to measure the ovarian size by locating the ovary, rotating the probe, finding out the longest section, freezing it on one frame of the dual frame, and on the other frame, you are going to just rotate the probe 90 degree without any other movement, freeze these two sections, take the longest diameter perpendicular to the long diameter on the long section, and on the transverse section, just take one side to side widest diameter parallel to x-axis. And the machine will calculate the volume for you. If you want to do it manually, it is x into y into z into 0.523. Now, why do we need to assess the blood flows? Is because it is important to understand that initially the antral follicles, they do not have their own blood supply. They depend on the stromal dispersion of the FSH for their initial growth and development of FSH receptors. So what happens here is only when the FSH levels in the stromal vessels reaches a certain level, which is called an FSH threshold, that is when the FSH is going to disperse into the stroma, and that FSH will be received by the antral follicles. The antral follicles now recognize this chemical, and then it develops receptors to itself, and these receptors then invite FSH by developing new blood vessels. That means that unless the FSH level in the stromal vessels reaches a certain level, the follicles will not be stimulated by, or follicles will not start growing. They will not develop receptors to FSH. Therefore, remember that if the ovarian stromal blood flow is more percentage of total gonadotropins, total FSH present in the patient's blood will flow into the ovary every cardiac cycle. So the FSH threshold will be reached easily, and therefore these follicles will start growing. Whereas if the ovarian stromal blood flow is less, to allow the FSH levels to reach a threshold, you need to put much more into the patient system. So very simple to understand. If the ovarian stromal blood flow is more, patient is a good responder. The ovarian stromal blood flow is less, patient is a poor responder. And there are multiple literature evidences to that. As in here also, you can read measurement of the ovarian stromal flow in the early follicular phases related to the subsequent ovarian response in the IVF treatment. And in the patients who are old age, where we know that the dose requirement is more, we all know that in the patients who are 25 years with say 5 follicles per ovary and an ovarian size of 3 cc, require much lesser doses for stimulation compared to the female of 35 or 40 with the same ovarian parameters. Why? Because the ovarian stromal blood flow is less. So with the aged patients, the ovarian stromal blood flow, the vascularization index and the vascularization flow index are significantly lower, whereas it is significantly higher in the PCO patients. And even in the patients with endometriosis, where we generally believe that the patients are going to respond poorly, even in these patients, if the flow is good, the response is going to be good. And this also holds true for the PSP and the RI. It has been concluded that if the ovarian stromal RI is less than 0.6 and the PSP is more than 10, patient is going to be a hyper responder. They require lower doses for stimulation. Whereas if the RI is more than 0.7 and the PSP is less than 5 in the stromal vessels, these are the patients who are going to require more doses, higher doses for stimulation. If that is true, how are we going to measure the stromal flows? As you locate the ovary, you should switch on the Doppler. When you switch on the Doppler, you will get a box. The box should be made large enough to include the entire ovary. And then as you span across the ovary, you will see vessels in the long axis which continue from outside the ovary. These are the hilar vessels. Consider hilar vessels as being in the hilar plane. And from there, when you span the probe on both the sides, you lose the vision of the hilar vessels, but you're still seeing the stromal vessels. Pick up the brightest ones and measure the flow. And this, you can do it on both the sides. And this is your stromal flow. If you find multiple vessels, this is the stromal vessel. Still, we are seeing a hilar plane. So we will not measure it here. We will go further laterally. Yes, now we are not seeing the hilar vessels. We can measure the flow in any of these vessels. And whichever shows you the best, lowest RI and the highest PSV is your decision maker for the stromal flows. But remember very well that whenever you are doing any of these scans, that is when it is important that your 2D image is good. The PRF for your color and power is set at 0.3. If there is no flow, don't decrease the PRF. If there is more flow, don't increase the PRF. The wall filter has to be set at low 1, and the gains should never be changed. Based on this, based on the age, BMI, AFC, ovarian volume, ovarian RI, stromal RI, and the stromal PSV, as we measured, we can decide what should be the stimulation protocol for the patient. This is a baseline scoring system which was published by us way back in 2016. And now we are about to present an evaluation of the scoring system on 8,500 patients with a multicentric study. And it has been proved to be very, very useful. Once your baseline score is calculated, that is when with every score, there is a pre-decided dose for IUI, IVF, and IVF fresh transfer and IVF frozen transfer cycle. That means it is your ultrasound who helps you decide the perfect dose. And this is a foolproof method. It results into 0 OHSS, 0 cancellation of the cycle because of poor response. Of course, because we have only 20 minutes, I will not go into the details of how the dose is modified. But remember that once the dose is decided by the starting dose based on the baseline scoring system, it is only in 20% of the patients that you might need to change the dose. Otherwise, the same dose takes you to the mature follicle. If during question answer time permits, we will discuss more about it. And it is useful for both IUIs and IVF. Not only that, it also tells you whether you need to add LH for stimulation or not. Now, generally, there's a big discussion on this, but just understand the physiology. What does the physiology say? The physiology says that the ovarian stromal flow is dependent on VEGF and LH. If the LH is more, there is going to be more new blood vessel formation, and it is going to be low resistance flow. That means that if the ovarian stromal flow is good, which means that the patient is going to respond well, which also means that the LH levels are sufficient. You do not need to supplement LH. But if the ovarian stromal blood flow is less, or it is high resistance, which means that the patient is a poor responder and is going to require higher doses for stimulation, it also means that either LH is low, or it is less perceived, or there is that because of receptor polymorphism, or it is less bioactive, and it is in these cases that LH supplementation is required. That means, just coming to a small conclusion, and that is, remember, your RI and PSV will help you decide what should be your daily dose of gonadotropin, and the ovarian stromal RI will help you decide whether this patients require LH supplementation for the stimulations or not. Then coming to towards the growth of the follicle, it is not just important to look at the size and the endometrial thickness. You need to look at the dynamicity of both the follicle and the endometrium. Apart from the size, assess the growth rate of both, assess the morphology changes of both, and assess the vascularity. You must start assessing the follicle from the time the dominance is achieved. And remember, dominance is not just a size of 10 millimeters. Dominance means its receptivity to the FSH, and this receptivity to FSH, as I explained you earlier, is diagnosed not by the size, it is diagnosed by the blood supply. When the FSH becomes dominant, that is when the blood, it pulls blood vessels towards itself, and you can see this is a dominant follicle, which actually starts showing flow as early as about a size of 9 to 10 millimeters. And remember, only the vessels which overlap on the follicular wall are perifollicular vessels. So when you see multiple follicles of 8, 9, 10 millimeters, only those follicles which show positive flow are dominant follicles, only those follicles are going to grow. So don't get worried by multiple follicles of 8, 9, 10 millimeters. But yes, if you truly have multiple, you might have to use Sono AVC, and I will not repeat the importance of that. The follicular growth rate after the dominance is achieved after FSH supply is determined. It is about 2 to 3 millimeters a day. We all know follicle usually ruptures at about 18 to 24 millimeters, or it is about at that size that the trigger is arranged. But remember that before 24 to 36 hours, you will see hypoechoic halo. You will see a tiny cumulus-like shadow. About 6 to 10 hours before, you would see low-level echogenicity separating from the inner wall of the follicle, which is for the release of the cumulus oophoris complex in the fluid. And around the same time, 6 to 10 hours, you would also start seeing niche-like shadows as a preparation of break of the follicular wall for the ovulation. But these signs only tell you when the ovulation is going to occur. The quality of the follicle can only be decided by the vascularity. The vascularity keeps on increasing after it has appeared with the dominance of the follicle. It covers at least 2/3 to 3/4 of the circumference. And you have, these are capillary networks. You have multiple vessels there. 2 days before the ovulation, 48 hours before the ovulation, which is the time when the final estrogen surge starts, the resistance in these vessels falls to less than 0.5. After that, the PSV rises. When the RI is less than 0.5 and the PSV rises to more than 10, this is the time when the surge the trigger should be given, or the surge occurs in a natural cycle. If it is a CC or a letrozole cycle only, and you're not going to plan an IUI, you do not need to give a trigger. Just follow the follicle. After that, it is going to ovulate, because the LH surge in these cases is adequate, endogenous. But if you have given gonadotropins, or you are going to plan an IUI in these patients, and this is the time when the trigger is to be given. Important to see the flows, because if the flows are not adequate, the oocytes inside are hypoxic, and the oocytes are hypoxic, this results into chromosomally abnormal embryos. Therefore, very important food for thought if you want to prevent or decrease the incidence of chromosomal abnormalities in the resultant in the neonates, or in the fetuses. You should ideally give a trigger only after you have seen the blood flows. You don't have control on the natural cycles, but you can at least do this in the treatment cycles, and you can decrease the incidence of chromosomal abnormalities. For the IVF cycles, also check the blood flows at least in 3 follicles on both the sides. This will help you prevent empty follicle syndromes. So we have assessed the follicle going to the till the time of trigger, but it is something very important which we must consider at this point, and that is what should be given as a trigger. Should we give HCG? Should we give agonist? And remember that whenever there are multiple medium-sized follicles, not large follicles, when there are multiple medium-sized follicles, 11 to 14 millimeter, that's when HCG leads to a higher risk of OHS. I will not discuss this theory here, no time. But the message is, if there are multiple follicles between 11 and 14 millimeters, don't give HCG as a trigger. But if there are multiple, if there are more larger follicles, don't give HCG to prevent multiple pregnancies. So this is something very, very important, and that is what ultrasound can decide. Looking at the endometrium, which is a receptor organ to estrogen and progesterone, becomes multi-layered, thickens in effect of estrogen, changes its morphology from grade B, this is hypoechoic, grade A, where intervening area is echogenic, and grade C, which is a homogeneous endometrium as the estrogen level rises. 1 to 2 follicles, 3 to 5 follicles, more than 5 follicles is what it correlates with. Over and above that, when endometrium has a definite growth rate, 1 to 2 millimeters a day in the early proliferative phase, and later 0.5 millimeters a day. The vascularity is also the effect of rising estrogen, which starts increasing with the dominance of the follicle, keeps on increasing. It must reach the inner layers of the endometrium, which is called zone 3 and 4. And it is these vessels which must cover 5 millimeter square area. Not only that, these vessels must have a low resistance flow where the RI is less than 0.6. And this tells you the endometrium has a good receptivity. If this vascularity is not there, chances of pregnancy, conception are less. If the conception occurs, the chances of abortion are very high. And therefore, endometrial vascularity assessment is also important. Along with that, it is also important to check the uterine artery resistance, and that should always be PI, and that should be always less than 3.2. So if I put the things together, follicle of at least 16 to 18 millimeters, vascularity covering at least 2/3 to 3/4 of the circumference, RI less than 0.5, PSV more than 10. For the endometrium, thickness of at least 6 millimeters, preferably 8 to 10. Vascularity reaching the inner layers, covering at least 5 millimeter square area, RI less than 0.6. For the uterine artery, PI less than 3.2. But if the surge has already started, the PSV rises fast. That means that the higher PSV tells you that the surge has already started. If the surge has already started, that is when the ovulation is not going to occur after 36 to 42 hours as usual. It's going to occur early. And if the ovulation is going to occur early, these are the patients who require an earlier IUI. And the message, again, final message is not going into the discussion because the time is almost running off. So if the simple message is, with the low RI, if the PSV of the follicle is more than 20, do 2 IUIs, 12 to 14, 36 to 38 hours. If it is less than 20, you can do just 1 IUI to get very good results. Early progesterone rise is one worry. And remember, progesterone exposure of the endometrium before ovulation is essential as long as it is within physiological limits, both duration-wise as well as the amount-wise. That is when you will get fluffy outer margin of the endometrium. And this tells you this is a physiological change. And if this occurs with a higher PSV, it is perfectly in synchrony with the follicle. And in these cases, you can go ahead and do an earlier IUI. But if the outer margin starts getting hyperechoic, this is not a good sign. It indicates a bad receptivity. So remember, if the follicle is mature, PSV is high, and you get these changes, fluffiness, decrease in vascularity of endometrium, and increase in the uterine artery resistance, tells you, yes, everything is in synchrony. But if you find this with immature follicle, it indicates a premature LH surge. And if you find it with a ruptured follicle, it means you should do an IUI immediately. So yes, ultrasound, I will not go further. So I'll just tell you that yes, ultrasound is a very important modality for monitoring and managing the cycles. It is useful to understand the natural cycle also, but without Doppler, you will not know the functional status. So the Doppler is very important. 3D may also help for the global assessment, and ultrasound, therefore, is the tool of choice for monitoring these cycles. Thank you very much for a patient hearing.
So thank you so much, Dr. Sonal ma'am, for your elaborate and comprehensive, overview of ultrasound, use of ultrasound. आपसे बेहतर कौन बता सकता है ma'am? So such good, ultrasound pictures and the way you have taught us. Thank you so much, ma'am.
Thank you.
Ma'am, your talk was excellent, awesome. We were in the awe.
Thank you.
If we could have a teacher like you, we would have been expert in the ultrasonography. Thank you, madam. Over to you, Deepika, for the next session.
Yeah.
So before you proceed for next session, I would like to say something.
Yes.
Congratulations, Sonal Ben, as usual.
Very
It was
much.
excellent.
Thank you.
And how result of infertility treatment could be optimum with use of ultrasonography was the theme of your talk. I could gauge it. But it was a very nice lecture and to the point, and with all the clear carry homes and basics.
Thank you very much, sir.
Sparing time to join our webinar series. Thank you.
Thank you. Thank you very much, sir. Thank you.
Thank you. So with sir's permission, now we move on to the next
Oh, yes.
session.
Oh.
And I've been told that Dr. Sujit sir will be speaking next. Sir, are you there? Dr. Sujit sir?
Yeah,
Yes,
I'm there.
Sujit is
So
there.
you are going next, sir? A second number.
Yeah, sure.
please.
If
Yes. Yes.
Dr.
sir.
Jaya permits.
Yeah,
If
we
Dr. Jaya
asked, we checked.
permits.
Yes, she will take the third session, sir. because- Okay, so now it is my pleasure to introduce our next speaker, Dr. Sujit Konkar, sir. Sir is a fetal medicine consultant. He is at MD OBGYN from GMC Aurangabad and has ultrasound training at Dr. Bimal Sahni Aurangabad. And is trained in basic invasive procedure training from Dr. Ashok Khurana sir's Apex Institute. And sir is the chairperson currently of Genetics and Fetal Medicine Committee FOXY 2026-28 and is the president of Society of Fetal Medicine Marathwada chapter. Sir, the stage is all yours. We welcome you. Please start with your topic, sir.
Thank you for nice introduction. And I will share. So at the outset, I would like to thank Patel sir and Monica for this opportunity. So my topic is Doppler in obstetrics, a very basic topic in day-to-day obstetric work. So Doppler is language of fetus to communicate with the clinician. So what is the clinical utility of obstetric Doppler? We will look trimester wise. In the first trimester, we look at ductus venosus and tricuspid as a part of aneuploidy screening. We look at uterine artery as a part of prediction of preeclampsia and fetal growth restriction. In the second and third trimester, we look at uterine artery, umbilical artery, middle cerebral artery, and ductus venosus as a part of screening and management of fetal growth restriction. We look specifically at MCA, middle cerebral artery, to detect fetal anemia. In any trimester, we look at fetal heart with color to know whether there is any suspicious abnormality. Whenever we found any abnormal mass or cystic lesion, we put in color and know whether it is vascular or not. And abnormalities of placenta and cord are very nicely detected by using color. So interested candidates can go through these basic ISWAP practice guidelines, use of Doppler velocimetry in obstetrics. Now coming to safety issues. Ultrasound is safe. There are so many questions and issues by new obstetricians, but ultrasound is safe. Transvaginal ultrasound is safe. Transvaginal Doppler is safe. But whenever you need to measure fetal heart rate in early pregnancy before 10 weeks, always you use M mode and not spectral Doppler for safety reasons. What are the differences in various modalities? Continuous phase Doppler means this modality continuously emits and receives the signals. The best example is the bedside fetal heart rate monitor, which we use routinely in labor room. Color flow mapping means any given area, when you put the Doppler in any given area, it tells about the color involvement of the vessels in that region. Spectral Doppler is the most widely and most useful in obstetrics. It gives various ratios. And power Doppler is non-directional Doppler, which is used for detect low velocity flows. So what are we assessing exactly? For that example, you take any vessel. There are two components, S and D, systolic and diastolic component. Systole tells you about cardiac pump and diastole tells you about end organ pressure. So this is my lecture outline: Doppler principles, uterine artery Doppler, umbilical artery, middle cerebral artery, ductus venosus, and aortic isthmus. So coming to Doppler principles. Doppler effect is the change in frequency of sound due to relative motion of source and receivers. Almost all of us might have experienced this, that when the vehicle is coming to you and approaches you and leaves you, the frequency of sound is different in each area. I am not going to details of this physics, but only remember that cos 90 is equal to minimum Doppler shift. See, cos 90 is minimal Doppler shift. That means when the angle of incidence is 90 degree, you get 0 deviation. And when cos 0 is equal to 1, that means when the angle of incidence is in line with vessel, you get maximum Doppler shifts. And again, effect of angle of incidence on spectral waveform. When the angle of incidence is aligned towards the vessel, that is, it is going towards the vessel, then you get positive waveform. And when it is away from the blood flow, you get negative waveform. So coming to Doppler principles. For absolute velocities, angle should be 0. And the only one thing which is more useful, mostly discussed in obstetrics fetal medicine, is MCV, fetal to detect fetal anemia. So whenever you are looking at middle cerebral artery to detect fetal anemia, the angle of insolation should be perfectly 0. But for other ratios, these ratios are angle independent. You need not be much worried about the angle of insolation, but it is very good practice to get the angle of insolation less than 30 degrees for each and every part. Now, what does the color bar tells you about? It doesn't tell you about whether it is artery or vein. It tells you about the velocities and range of mean velocity displaced. Light colors are depicted by high velocities, and dark colors tells you about low velocities. Now, how to optimize? These are some basic things: PRF, gain, filter, balance, gate size, and movement. Now, coming to velocity scale, you see, for example, here the velocity scale is set at 48 centimeters per second. This means that when you start exam, when the velocities are low, you get dark color. When velocities are high, you get light color. But if the velocity of the vessel is more than 48 centimeter, it again goes to blue and there is aliasing. So the importance of this thing is that you should know the velocity of the vessel which you're looking at. For example, the velocity of uterine artery is more than 60 centimeters per second. So this setting is not perfect for uterine arteries. Again, is filter. Filter is the area between these two lines, this red and blue line. So high filter is used in cardiac settings, not in the routine obstetric setup. Balance is this green line is the balance. It is the balance between grayscale and your color. So if you want to mask the gray thing totally, you have to balance should be your high. Your balance should be high. But if you want to look at the things along with grayscale, your balance should be low. For example, when you are looking at fetal heart in lateral view for interventricular septum, and if you keep the balance low, you can see nicely the interventricular septum and is there any small ventricular septal defect is there or not. Then gain. This is the gain. And if the gain is more, the vessels, the diagrams, the vessels bleed on the screen. So gain should be minimal in these settings. So what are the Doppler indices? RI, resistivity index, pulsatility index, and SD ratio. But routinely in our practice, we use pulsatility index only because it shows linear correlation with vascular resistance. And even if diastolic velocity is 0, it does not reach infinity. The only other parameter used is peak PSV, MCA PSV for fetal anemia. This example shows the ratio which are angle independent, because here the angle is 0, here angle is 40, and here angle is 0, but there is no difference in the PI and RI values. So coming to basic Doppler testings, you have to zoom the area of interest, apply color Doppler, narrow the color box, and adjust the velocity scale according to which vessel you are looking at. Then apply pulse wave sample gate adjacent to the or the cover vessel and adjust the filter. An angle should be close to 0 as far as possible. Now, what are we targeting at? Some are placental tests, some are fetal tests. Umbilical and uterine artery Doppler are placental tests because they reflect fetoplacental and uteroplacental resistance. And fetal middle cerebral artery and ductus venosus, these are fetal tests because they indicate response to adversity. So what do these vessels represent? Uterine artery tells you about trophoblastic invasion. Umbilical artery tells you about placental venous obliterations. MCA tells you about brain sparing. Aortic isthmus gives information about redistribution of cardiac output, and ductus venosus is a reflection of myocardial function. And how to measure percentiles? We discuss a lot about things about, and the percentile word is used very frequently. So there are two ways. One is most of the fetal medicine softwares, reporting software, they are already having this percentile issue. Once you put the information in that, the percentiles values are automatically shown on the screen. Or you can go for this fetal medicine Barcelona calculators, which is available freely online. Then coming to uterine artery Doppler. Uterine artery is branch of anterior division of internal iliac artery. It enters the myometrium at the junction of uterine corpus and cervix. Why and when? We start to look at uterine artery 11 weeks after 11 weeks in all cases. In the first trimester, we look at it to screen for preeclampsia. In second and third trimester, for assessment of fetal growth restriction. Remember that when umbilical artery is abnormal, the value of uterine artery is lost. Then it can be seen transabdominally as well as transvaginally. In transabdominally, you have to, in the first trimester, we look transabdominally. You have to take the sagittal section of uterus, identify the cervical canal, and zoom it and put in color. Tilt the probe to right side, you get right uterine artery. Tilt the probe to left side, you get left uterine artery. In second trimester, you have to search the uterine artery in the right flank, just above the intersuperiliac spine. After finding it, after getting it, you have to zoom the area. Pulsar Doppler is used. Sample volume is placed 1 centimeter downstream at the crossover point at this level. Sample gate should be 2 millimeter. That means it should cover the vessel. Angle of insertion should be less than 30 degree. And remember that here PSV should be 60 centimeters per second in all cases. So whenever we are looking at uterine artery, because if the PSV is less than 60 centimeters per second, it is not uterine artery. It could be another vessel or arcuate vessel. When 3 consecutive waveforms are obtained, PI is measured and mean of right and left is taken. In non-pregnant state, there is high resistive flow with low diastolic flow in uterine artery and there with early diastolic notching. Now coming to trimester-wise distribution of uterine artery. You can see here, as the gestational age advances, the impedance and resistance to blood flow decreases. The volume of blood flow in diastole increases and the PI value goes on decreasing. So these are the cutoffs according to first trimester, second trimester, or third trimester of the uterine artery. But instead of using cutoffs, it is always better to use language of percentiles. That means uterine artery is falling on so and so percentile for this gestational age. That is the better way for describing this. And as all of us know, when the uterine artery PI is more than 90th centile, we start low dose aspirin, which is wonder drug for prevention of preeclampsia. Interested delegates can go through this beautiful article, How to Record Uterine Artery Doppler in First Trimester by Asma Khalil and Nicolette's group. Then coming to umbilical artery Doppler, it arises from internal iliac arteries from the fetus. It carries deoxygenated fetal blood to placenta and oxygenated blood returns from the placenta by the way of umbilical vein. So when and why? We start to look at the umbilical artery after 24 weeks in single-cell pregnancies, and in twins and multiple pregnancies in monochromatic twins, whenever we suspect twin-twin transfusion syndrome, then again, regardless of any gestational age, usually we look at this after 18 weeks, every 2 weeks. And why? Because umbilical artery reflects the fetal placental resistance, if there is any risk of fetal growth restriction or poor parental outcome, and again, it is important for staging of TTTS. Now, how we look at it? We have to look for the free floating loop in singletons, not to the attachment near the placenta or not to the attachment near the baby's womb, because the values may be high or low depending on the resistance of the flow. In multiple pregnancy you have to sample just distal to abdominal cord insertion, because you have to identify the exact vessel or exact baby. Fetus should be at rest and not breathing. This is very, very important, or you may get wrong readings. Angle of insertion is not very much crucial, but as far as possible, get angle of insertion less than 30 degree. And if there is 2 vessel cord, the vessel is bigger, dynamics are different, you have to report very cautiously in these cases. So normally, as the gestational age advances, the resistance and impedance to this umbilical artery goes on decreasing. The blood flow during diastole goes on increasing, and the PI values goes on decreasing. So normally, diastolic blood flow is not detected in first 10 weeks. It can be detected by about 15 weeks onwards. So this is very nice article about this percentile values. Use of percentile is the message today, and normal value is when the umbilical artery PI is less than 95th centile. So what are the abnormalities in this case? What abnormalities can you see? High uterine umbilical artery PI, when the umbilical artery PI is more than 95th centile, it tells you when the more than 30% villi are damaged or underperfused. When the umbilical artery, there is absent end diastolic flow, more than 50% villi are underperfused or damaged. And when there is reverse end diastolic flow, there is severe grade of damage, more than 70% villi are damaged. And this is the normal waveform. This is absent end diastolic blood flow, and this is reverse end diastolic blood flow. Now, here are some tips when we are studying umbilical artery Doppler. If PI is abnormal, measure both umbilical arteries and use more normal value. Sample approximately mid umbilical cord. perform Doppler at the start of scan, and if abnormal, repeat at the end of scan. That means, meanwhile, you look for other vessels. And during fetal breathing movements, there are variations in the shape of waveforms, wait till apnea, and also you have to care for maternal breathing. Now, next is middle cerebral artery Doppler. Why do we look for that? We look for that looking for to monitor fetal growth restriction, especially in late FGR cases, to measure pulsatility index and CP ratio. And it is a very good non-invasive assessment of fetal anemia to measure PS, peak systolic velocity. So what is the pathophysiology? What happens in hypoxia? The carotid receptors are stimulated, and there is centralization reflex. That means blood flow is more diverted to more important organs like brain, adrenals, and fetal heart. So the blood flow to brains is high. So PI values goes on decreasing. It drops. And what happens in anemia? Because of fetal hemolysis, there is a drop in fetal elasticity, increased flow velocity, and MCA PSV increases. So how do we get this? You have to get at the axial section of brain, go to the base of skull, zoom it, enlarge it, put in color. You say you get this beautiful circle of Willis, and put the gate at the origin of middle cerebral artery. Gate should be 2 mm, and you get this beautiful trace of the middle cerebral artery. So what is normal? Normal flow of MCA in first trimester is, and second trimester resistance. It is in contrast to umbilical and uterine arteries, because in those vessels, as the gestation advances, the resistance goes on decreasing. But normally there is high resistance flow in MCA, and when the MCA PI values are falling, it is abnormal. It indicates brain sparing effect. So less than 5th centile is supposed to be abnormal. So again, peak systolic velocity, it can be studied since 18 weeks onwards, especially in monoclonic twins. Here, angle of correction is very, very necessary. Angle of insertion should be correctly 0 to get WOM values. And when the WOM values are more than 1.5 WOM, these are abnormal values. So there are some pitfalls in looking at MCA Doppler. Causes of reverse diastolic blood flow in MCA are compression by probe. So avoid excessive compression, impeding fetal death, and some cardiac anomalies. So cerebroplacental ratio, this needs mention here. It is the ratio of MCA PI to umbilical artery PI. Normally, at any gestational age, MCA PI is more than umbilical artery PI. So what happens in hypoxia? Umbilical artery PI is high and MCA PI is low, and the ratio is reverse in abnormal cases. It has greater sensitivity than assessing MCA and umbilical artery Doppler in isolation. Less than 5th centile is abnormal. Low or abnormal outcome is associated with adverse perinatal outcome. In some cases, umbilicocerebral ratio is used. CPR can be abnormal even when individual PI in MCA and UR are within normal limits. So this is the more sensitive marker. And another important message here is CPR is surveillance tool, not trigger for delivery. Trigger for delivery in late FGR is abnormal CTG. Now next is ductus venosus Doppler. It is a small trumpet-shaped connection between umbilical vein and inferior vena cava. It carries oxygenated blood returning from the placenta directly into right atrium. So we start to look at it after 11 weeks for screening for aneuploidy and for cardiac defects. In second and third trimester, it is useful in 4 circumstances: for monitoring of fetal growth restriction, assessment of cardiac function and strain, assessing treatment response in SVT, and staging in TTTS. So ductus venosus evaluation is cornerstone for assessing when to deliver in early onset FGR. So ductus venosus is very, very important when we are managing early onset fetal FGR cases, and CTG, abnormal CTG and CP ratio are useful in late FGR cases. So how do we look at it? So fetus should not be moving. Again, it should be resting. Right ventral mid-sagittal view should be there. You have to magnify it so that only this area of the chest is seen on the screen. Put in color, look at umbilical vein, inferior vena cava, and aliasing ductus venosus here. Sample gate is very, very small here because the vessel is very, very small, 0.5 to 1 mm, usually 0.7 mm is used. Angle of insolation should be kept ideally less than 30 degree. Frequency filter should be low here because this is very, very small vessel, and there should be high sweep speed for better assessment. Sweep speed means the number of this projection on your screen. That should be high so that you can study each parameter very nicely. In second and third trimester, it can be seen by oblique transverse plane of the abdomen, Ductus venosus is seen at far end of continuation of umbilical vein, like this here. Then normally this is triphasic waveform, S wave, D wave, and A wave. S wave denotes ventricular systole, D wave denotes ventricular diastole, and A wave tells you about atrial contraction. And normally there is always forward flow during atrial contraction. So what are abnormalities in this? So this is the normal value. This is the high PI, ductus venosus PI more than 95th centile, absent A wave, and this is the reversed A wave in ductus venosus. So these are the other causes of ductus venosus abnormality, not related with FGR. These are the structural defects. Now coming to aortic isthmus. Aortic isthmus is not routinely included in a routine scan. It is controversial vessel to be included in our routine practice, but I will spend a few minutes here. Aortic isthmus is the area when between the left subclavian and the ductus arteriosus. So what happens here is the oxygenated blood coming from left ventricle come from descending aorta and it supplies head neck vessels. It is the purest blood, oxygenated blood. And here the blood from right ventricle, which is less oxygenated, it is mixed blood, come from here and goes to the descending aorta. So what happens when the resistance in the head neck vessel is low? The blood flow from this area, right ventricle, instead of going down, it goes up. So head neck vessels get deoxygenated blood, and that results in poor neurological outcome in fetuses. So this is the normal waveform. Upward stroke of left ventricle, sharp dip of right ventricle, early systolic reversal here, and diastolic flow is always there because of less placental resistance. This is the normal flow, and this is the abnormal flow. It is the reverse flow you can see in this direction. So when the resistance in placenta is less, there is forward direction. It's in normal cases. When the resistance in MCA is less, which is seen in late FGR cases, there is backward direction. That means this deoxygenated blood goes to the head and neck vessels, and brain gets this blood, which is cause of neurological deficits in these babies. So it reflects the balance between impedance of brain and systemic vasculature. Normally, aortic isthmus always reveals forward flow during diastole. The reversal of flow in aortic isthmus is a marker of poor neurological outcome in FGR fetuses, and reversal of flow in aortic isthmus precedes DB abnormalities by 1 week. But to get this aortic isthmus examination in routine study, more research is required. So the interested delegates can go through these beautiful articles to know more knowledge about this. The pitfalls are: net reversal is seen only after severe umbilical artery abnormality. It becomes abnormal before ductus venosus. It is highly specific but not specific. So coming to last slide, Doppler is now integral component of almost every obstetric ultrasound. You should know the basics of Doppler. How to take the waveforms and how to understand the waveforms. Not only technical aspects but also interpretation is very, very important, because interpretation is what everything is depending on the management of the patients. And abnormal Doppler is not equal to cesarean section. You have to think very cleverly in these situations. Thank you for being online.
Thank you, Dr. Sujit. That was an excellent deliberation. Today we have stalwarts speaking on ultrasonography, and I think it's one of the very interesting sessions which we have heard for a very long, in the Happy Life series.
Thank you.
So moving on to the next speaker, we have a Professor Dr. Jaya Chawla, and she's a professor at Department of Obs and Gynae at IMS, as well as Dr. Ram Manohar Lohia Hospital. She's the National Coordinator, Genetics and Fetal Medicine Committee, FOGSI 2026 to 28. She's the Executive Member of Genetics and Fetal Medicine Committee, FOGSI, since 2023, and the Secretary, Society of Fetal Medicine, Delhi Chapter, 2024 to 26. She's also the Executive Member of Fetal Medicine and Genetics Committee.
Thank you so much.
Okay.
Thank you.
Really fantastic command over the subject of fetal medicine, and the best person, I think, to do justice to the subject. Okay, Dr. Jaya.
Thank you so very much for those very kind words, Dr. Nivedita. I will be focusing on the first trimester scan primarily for today's topic. And before I start, I would like to thank Dr. MC Patel, sir, for this opportunity. Thank you so very much. So the outline would be that we'll be discussing the basics And then focusing on how can aneuploidy screening be aided by a first trimester scan? How can early morphology scan help us in picking up malformations? How can multiple pregnancies be deciphered further with the use of the scan? And can we screen adequately for preeclampsia and growth restriction through this ultrasound opportunity? So once we come to the basics, we want to say that the thermal index for any scan has to be kept less than 1 in order to prevent harm to the baby. The exposure time has to be as low as is reasonably achievable, and that applies to all our scans. The fetus has to be in the period of quiescence, not jumping around for us to take our recordings, and preferably examinations of Dopplers, like what Dr. Sujit has already mentioned, should be done under voluntary maternal breath. Now, the gestational age window for the first trimester scan is the 11 to 13 plus 6 weeks, as we all know. We first measure the CRL and find it to be between 45 and 84 millimeters before we proceed further. The route of examination is transabdominal first, like always. But if we want to decipher something more in detail, and we think that our transabdominal examination is not giving us enough window of visualization or opportunity, then we resort to a transvaginal scan to gain more information. So why 11 and why 13 plus 6 is so plastic? It's an important question. And we need to understand that 11 weeks is the lower limit, because any confirmatory test that you might want to embark upon after you have found an abnormality in the scan can only be provided after 11 weeks. And prior to that, there's a risk of transverse limb reduction defects. So there is no point creating anxiety in the mind of a parent if you cannot provide solutions. Second is, beyond this time limit, it is an opportunity for us to do an early morphology check, which is vital in today's times to pick up abnormalities as soon as we possibly image them. 13 plus 6 weeks and beyond, the fetus becomes more vertical, and therefore our idea of a transverse image of the crown to rump length no more holds good. Secondly, we are here to measure the nuchal translucency as the scan began forthwith with, and that translucency, that fluid behind the neck, tends to disappear with time in many babies who are chromosomally abnormal. And so this window is crucial to pick up that fluid behind the neck, which might disappear at a later gestational age. And third, of course, is the opportunity for a first trimester termination in case it is so indicated, rather than a second trimester termination, which can have risk potentially to the mother's life. So coming to the nuchal translucency measurement after the CRL, like we said, the CRL we all know, as seen in the previous idea, the baby has to occupy 2/3 of the entire screen. The baby has to be in a neutral position. Endpoints at both ends should be visible and full of fluid so that we know that this is the endpoint and this is the endpoint. And the baby should be in a perfect sagittal plane. Once we have acquired this image, all fetal medicine people are on cloud 9, trust me, because all the rest of the imaging that we want to do basically is in parts of this very image. So we can go to our Cine loop, magnify the required parts, and measure whatever else we want. So coming to nuchal translucency measurements, we all know that this is a collection of fluid behind the fetal neck. So fetal neck, upper thorax and head have to be in complete focus and have to occupy 2/3 of the screen. We want a perfect mid-sagittal view and a neutral position. So how do we identify that this is the case? So as you can see here, the nasal bone is visible. The zygoma is there. The palate is there, and the zygoma is not there. The palate, the square thing, is visible. And there is fluid between the baby's chin and the thorax. These three conditions, when they are met, you are reasonably sure that you're looking at a perfect mid-sagittal view and baby is in a neutral position, whereby what I mean is that if the baby's neck is fully flexed, as in this case, and you don't find any fluid between the neck and the thorax, then this will give you an erroneously low NT. Whereas an extended fetal neck, on the contrary, will give you a higher NT, and that is what we do not require. Also, we require the baby to jump forward in this instance because we often confuse the skin with the amnion. So when the baby jumps, we are able to distinguish the two and identify the nuchal translucency correctly. We have to measure the widest part of the translucency So either ways, both sides on the red arrows are not okay. We need to have end to end, which means the horizontal line of the bar merges with the baby's layer. Now you can see here that many of the times we do not find that beautiful NT image because the fetus is completely encased in a layer of fluid, and a thick one at that. This is what we call a cystic hygroma, and this baby turned out to be a Turner's. Now, what are the causes of an increased NT? We could have cardiac defects. We could have venous congestion secondary to a superior medius channel compression, like an early onset skeletal dysplasia or a diaphragmatic hernia. We could have altered composition of the extracellular matrix as an achondrogenesis or achondroplasia. We could have failure of lymphatic drainage, for example, single gene disorders like the Noonans. We could also have fetal anemia such as alpha thal or a Blackfan diamond anemia. Also, Fanconi's can present like this. We could have fetal hypoproteinemia and fetal infections. The reason of displaying this list here is increased NT does not straight away mean trisomy 21. Yes, increased NT will be found in 75 to 80% of fetuses with trisomy 21, having an NT thickness of more than 95th centile. However, increased NT is also associated with numerous genetic syndromes and single gene disorders. It is also associated with fetal death, but in majority of cases, this NT resolves and the babies are born healthy. And that is an important idea to take home, because increased NT, parents will come and ask you, we want to terminate this pregnancy because we read so much about it on Google. But we all understand that that's not the case. Increased NT beyond 99 centile specifically calls for invasive testing. We have to do a CVS and send the sample for a FISH or a QFPCR, and also a chromosomal microarray that detects microdeletions and microduplications. We have to store the DNA further, because if these turn out to be normal, we might have to look at single gene disorders. A detailed mid-trimester evaluation for malformations would be required, and also to see whether the nuchal has persisted or has resolved. And next comes the core role of fetal echocardiography and genetic evaluation for alpha thalassemia in case the mother's MCV is less than 80 femtoliters. Above all, reassurance if all of this turns out to be fine. So what if the increased nuchal does not resolve in the second trimester? Then we have to think of infections like toxo, CMV or parvovirus. We have to think of single gene disorders and proceed with testing for the same, which is why storing DNA is extremely important. Follow-up scans every 4 weeks to see if the edema resolves or increases, and counsel regarding 10% risk of perinatal death or the baby being born with a genetic syndrome that has not been able to be diagnosed prenatally. All in all, a risk of neurodevelopmental delay in survivors to the tune of 3 to 5%, just in case the NT does not resolve by the second trimester. The next comes the four-chamber view of the heart, wherein we put our Dopplers and see the fetal heart rate. Now, why do we need to see the fetal heart rate? The reason being, on our biochemical screening in the first trimester, that is a dual marker, both trisomy 18 and 13 give us a low PAPA and a high HCG. So it is the fetal heart rate that can distinguish between these two to a certain extent, because fetal heart rate in 90% of individuals with trisomy 18 is decreased, and in 90% of individuals with trisomy 13, it is increased. So which is why all our calculators, as you have seen, include FHR in their algorithm. Here I would like to say that every patient has a priori risk or a background risk of aneuploidy, which is created based on a maternal age and gestational age. This a priori risk is something you don't need to get into any investigation to identify. Once we have identified an a priori risk, then every time we look at an ultrasound and a marker is added, whether it is abnormal or normal, then the likelihood ratio of that marker creates the new risk for us. And that is how we screen patients. So the next marker that is going to increase our a priori risk, once our nuchal has come out to be more or less, is the nasal bone. Here we have to have the same plane that we had for the nuchal. We have to look at the nasal bone, the overlying skin, and the echogenic tip of the nasal bone, and identify that this bone is either more echogenic or equal to the skin. If it is less, and even if it is equal, it is abnormal. It has to be more echogenic compared to the overlying skin for us to be able to say that the nasal bone is ossified. What happens when this nasal bone is absent? Like in this case, you see, it is not as echogenic or more echogenic as compared to the overlying structure. Here we have to understand that this is not only a risk for trisomy 21, but also a risk for trisomy 18 or 13. Especially the risk gets compounded when the fetal nuchal is higher in such a baby. However, absent nasal bone at this scan is not an indication for termination of pregnancy. There's an indication for follow-up, repeat scan at 16 weeks. And if in the second trimester also the NB continues to be absent, then we should be resorting to invasive testing. Ductus venosus is the same image for the CRL, but this time we have to zoom the image containing the thorax and the upper abdomen, and we have to focus on the umbilical cord insertion and where this umbilical vein joins the inferior vena cava. We have this aliasing, the yellow aliasing that is clearly visible. We put a cursor there. The gate has to be narrow to 0.5 to 1 millimeters because it's a tiny vessel, and we have to look at the waveform, which is either, it's a three-phasic waveform. The systole, the diastole, and also the atrial systole is recorded here. This atrial systole is of particular importance to us because a positive A wave is normal. Even an absent can do, but a reversed A wave is a hallmark of risk of aneuploidy, risk of cardiac defects, and risk of sudden death. So again, 80% of cases with reversed A wave come out to have a pregnancy outcome which is normal. And therefore, invasive testing is warranted. Fetal echo to rule out cardiac abnormalities is warranted. Yet, time and again, I would emphasize, termination of pregnancy is not warranted in these cases. The risk of fetal death when a DV-A wave is reversed is about 2% between 11 weeks and term. And therefore, fetal growth has to be monitored at every 4-weekly intervals beyond the second trimester scan. Of course, the uterine artery and umbilical Dopplers have to be seen. Tricuspid regurg, 4-chamber view of the heart. We take 3 different values so as to engage the entire tricuspid valve. The gate has to be large, the sweep speed high, and we have to see that the velocity, the regurgitation, if it occupies more than 50% of the systole, and if the velocity is more than 60 centimeters per second, then only you call it tricuspid regurg, and not otherwise, comparing it with the image on the top. Now, the risk of increased NT gets compounded further when the DV is abnormal or tricuspid regurg is present. However, when we talk of likelihood ratios, we also talk of the markers which are not present, because that means the negative likelihood ratio brings the risk down as well. And therefore, an increased NT, the risk of which can be neutralized potentially by a normal biochemistry, by a normal A wave at the DV Dopplers, and by the absence of tricuspid regurg. And therefore, all of them independently contribute to risk assessment. However, an increased NT beyond 99 centile, even if the combined risk comes out to be intermediate, is an indication for invasive testing, and that should be clearly taken home. Also, when you do a PAPE in a dual marker test, a more of 0.3 or less has an odds ratio of 2.74 to suggest that the birth weight in the 3rd trimester is going to be low, and therefore not just aneuploidy, but dual markers also give us a hint about growth restriction, and therefore any PAPE value less than 0.4, one should keep a high risk in their minds for fetal surveillance in the times to come, at least every 4 weeks. Now, when we talk of maternal age, we are only able to identify 30% of individuals with aneuploidies, and these days majority of women are conceiving late. So, maternal age in itself can be a high risk factor for screening, but by no means a complete screen, and we need to add other stuff. And often we get in clinical practice individuals who have a good dual marker but not an NT, who has an NT but they miss their dual marker, and therefore individual percentage points for counseling are really important on medico-legal basis. And whenever in doubt, or whenever you think a combined first trimester, a good combined first trimester has not been offered, offering an NIPS as a contingent screen can actually save it for us. Now, since my talk here is going to focus on scan per se of the first trimester, now I'll be taking you through the early morphology scan. And therefore, this is the fetal brain as you see in the mid-sagittal section. Here you can see that there are 3 lines and 4 spaces created in the mid-sagittal view. This is the nuchal translucency. This is the future cisterna magna, and this is the intracranial translucency. So it is important to take care of all of these aspects if we need to know the future development of the brain. Also, the 4 quadrants of the brain, this is the typical choroid plexus view that we used to include in all our scans earlier also, but this is the anterior segment, the thalamic view, and the cerebellar view. We need to understand that vermis here is categorically going to be absent or ill-formed in the first trimester, and we do not really comment upon that in this trimester in order to save patient anxiety. Next is the fetal spine, the ear, the stomach bubble, etc. Here you see the spine. Here you see the urinary bladder. All of these are to be commented upon. The diaphragm can be visible. Limbs are visible, and all of that needs to be taken into consideration when you formulate your report. A 4-chamber view, the left ventricular tract, the 3-vessel trachea view. All of these are important as early screening tools. However, there is a great red flag over there. There are only a certain set of anomalies that can be identified in the first trimester, such as acrania and cephalocele, lobar holoprosencephaly, cardiac defects like tricuspid atresia, pulmonary atresia, or pulmonology of Cantrell, ectopia cordis, gastroparesis, and body stop abnormality. For the rest of them, we cannot be very sure in the first trimester. They're liable to be missed, liable to be falsely diagnosed as well, and therefore the patient has to be followed up in the second trimester with a good screen again to be able to suggest whether the case was present or not. So here you see that this is a case of anencephaly. Of course, this can be diagnosed in the first trimester. This is enencephaly. You can see the neck is completely extended and permanently so. This is a first trimester omphalocele, as you see, at 12 weeks plus. Then you see this is gastrocystis. This is lobar holoprosencephaly and body struck abnormality. Megacystis, and here you see that the arm goes no further, so that's a limb reduction defect. Coming to multiple pregnancies, it is important to identify chronicity and amnionicity, which can be beautifully done in the first trimester based on the lambda or the T sign. It is important to look at the image provided to you by the fetal medicine person or the radiologist. Please do not succumb to the idea of only reading the report, because we have seen in practice that sometimes the report and the image do not gel with each other. It is a mandate by major guidelines at today's times that they have to be producing images, and those images have to be preserved till the birth of the baby. So take into practice that looking at the lambda or the T sign, and here you see that this is a monoamniotic monochorionic twin pregnancy. Always put color to see the cords are entangled or not. Now, here you see that there is an amorphous mass that does not show cardiac activity in one corner of the image. The other corner of the image, we're going to see a baby with an increased NT, of course. This is what we refer to as twin reverse arterial perfusion. That's another case with similar findings, as you can see. So it's an arranged large NT and an amorphous mass on the other side. So another case of trap. Now here you see a triplet. So in triplets or in higher order gestations, only nuchal translucency and maternal age can be combined together to come to the risk of aneuploidy, and therefore it is absolutely essential. Looking at the placenta is essential again, because here you see a placental chorioangioma at around 13 weeks and 5 days. So screening for preeclampsia, another important idea. We know that instituting aspirin prior to 16 weeks reduces the risk of preeclampsia, especially preterm preeclampsia, by a substantial margin. And therefore, the 11 to 13 plus 6 week scan offers us the opportunity to identify a subset of individuals who are at a higher risk for preeclampsia and institute aspirin prior to the second wave of trophoblastic invasion being present. So here what we do is the transabdominal technique. It has already been taken in detail by Dr. Sujit, so I will not be taking it in detail. Suffice to say that 11 weeks 2.7 is the norm, 12 weeks 2.53 is the cutoff, and 13 weeks 2.38 is the cutoff. So by and large, if you remember these numbers, you'll be able to identify where it is going wrong. And it is important to put this into the algorithm for preeclampsia risk calculation, which involves maternal age, BMI, the maternal demographic factors, parity, crown-to-rump length of the baby, the uterine artery PI, the mean arterial pressure, and of course, markers like PAP-A from the dual marker, if you have one, and PLGF, if you can manage to have one incorporated. And you get a risk which can tell you whether to institute aspirin or not. What happens when you do not have any of these markers, for example, the PAP-A or the PLGF, you don't have the uterine artery, you can still go ahead and take the calculation based on demography and mean arterial pressures. Uterine artery majority of times is given in the first trimester scans these days, so that can be incorporated. Coming to ophthalmic artery Dopplers, which is the future in today's times. So because these are easy to navigate, uterine artery has a learning curve, ophthalmic artery has a lower learning curve. Here you see that there are two peaks in the ophthalmic artery Dopplers, and you take the ratio of the first to the second peak, that is P2 by P1 ratio. The algorithm provided by Fetal Medicine Foundation will take a while to incorporate it, but the moms have started to appear, the percentiles have started to appear, and in due course, we can have an insight based on incorporation of ophthalmic artery Dopplers into the algorithm as well. Coming to the take-home messages, a scan at 12 to 13 weeks is important because it minimizes repeat evaluations. So if you were to see an absent nasal bone at 11 weeks and repeat the scan at 13 or 13 plus 6, it is rather better to schedule the scan at around 12 weeks and do your biochemistry at 10 weeks in order to get the maximum benefit out of a combined first trimester screening. Perform TBS when in doubt, especially when you're going to look at a twin pregnancy or a higher order gestation and comment upon amnionicity. It is always better to look at the transvaginal scan because a membrane which was not visible through an increased BMI mother on a transabdominal scan can very well be visible on a transvaginal scan. Majority of babies with raised NT survive and develop normally, and therefore you have to reassure, of course, only after invasive testing, fetal echo, detailed NT scan, and follow-up. Evaluation for malformations and screening for preeclampsia are an important part of the exam, should not be missed. My final word on this platform will be, the aim of the examination is to provide insights and not scare. Since the target audience today is OBGYN people, I just have a humble request. Whenever we ask for a first trimester scan, ask for aneuploidy markers, ask for early morphology scan, ask for preeclampsia and FGR screening, because the answers are only as good as the questions. Always look at the images before you jump to the conclusion of a certain report that is given to you. And if the image is suboptimal, please record that on your OPD sheets because medico-legally that saves. Thank you so very much for very patient listening. Thank you, Patel sir, for the opportunity yet again.
Excellent deliberation, Dr. Jaya, and this inverted pyramid of care which you've just mentioned about the first trimester screening and given insights about the various aspects of obstetrics that we can evaluate right at 11 to 13 weeks, 6 days scan. Thank you very much for this deliberation, and we'll move on to the fourth session for today. Do we have the next, Dr. Monica? Okay, could we have the next, the speaker for the next session? Could we have the CV for the... Maybe my network is poor because I'm just, what's going on?
Ma'am, I can do it, no problem, I'm there.
Thanks, Shatabdi. Dr.
Yes.
Jaya, this time I just needed to ask one question. if there's time, if we have time till the screen is coming on. A lot of times I've seen when we get the NT&B scan done, even a CRL of 84 shows or even 82 will show 14 weeks 1 day or 14 weeks 2 days, and the dual marker is regretted. So I mean, what is your take on that? Because I get them
Very
done as a
clear.
routine.
It's a very good question of practical significance. The dual marker upper limit we normally take in our laboratory is 13 weeks now.
Yeah.
And the NT scan is permissible up to 13+6. Also, the CRL, when we measure at 84 millimeters, corresponds to, in some conversion factors, up to 14 and 14+1 days also.
Yeah.
Which is why what we do is that anytime a scan is brought to us, we first measure the CRL in an appropriate plane and then only determine whether we can go further with the detailed scanning or not. Because LMP and NT scan CRL can have a dichotomy of a couple of days here and there. Up to 5 days is very well known. So what we do is we measure the CRL and that becomes our dating scan. And based on that, we decide. And in order to get the maximum from your combined first trimester screen, it is advisable that biochemistry is offered close to 10 weeks because the difference in PAPA amounts is the maximum at that point of time. It goes on minimizing as you reach the 13 weeks window.
True.
So it is always advisable to confirm the dates. And if we have a viability scan, which is corresponding, is excellent. And then we go ahead, do a biochemistry at around 10 to 10 plus couple of days, weeks, and offer the scan at 12 weeks and incorporate the two. It is the practice of incorporating both at 12 weeks is because we minimize the patient's visit actually.
Yeah,
But
and plus, plus they won't do the dual marker, the PAPA and the beta HCG without the NT and NB.
Actually, that is again a bad practice. Ma'am Vandana can allude to it further, that you don't really require it that way. The maximum detection rate is going to be when your biochemistry is done at 10 weeks, when NT scan is actually not applicable. NT will be done later. And you integrate the two and you get your best detection rate, least false positive rate.
Okay.
So, madam, both are right. What Dr. Jaya is saying, that by biochemistry, it is best to do at 10 weeks and the NT at later time. But in clinical practice, we cannot call a patient at 10 weeks first and then call at 12 weeks and then integrate. So the labs are not used to this 10 weeks report and adding on an NT later on. So
Absolutely.
it's best to do not at 11 weeks because the structure is not so well seen. Better to do in the 12th week itself, when we would have an average of both the things and we can see the structure also better and the NT also better and a biochemistry also. So practically it is good to do it at the 12th week, 12 to 13 plus weeks for clinical.
And also this absent NB thing, which has become the talk of the town. Because earlier to do the scan, the NB has not appeared, and then it becomes a very big red flag that absent NB and the Googleized opinions of people.
Absolutely.
Involuntary terminations take place because of that. The closer you go to the 12 to 13 weeks bracket, the NB is likely to appear, be ossified, and you can allay the anxiety of the parent.
Yes.
And measurable. True.
Yes.
Thank you.
Thank you,
Dr. Jay and Dr. Vandana. And the next speaker is Dr. Vandana Bansal, and she's going to speak on mid-trimester anomaly detection. Could we have a CV? Because she's an excellent orator too. I've heard her speaking on RH negative pregnancies, but let's take on today. We have a totally different take on, and she's additional professor of Obs and Gynae and head of ultrasound department at Nauroji Vadia Maternity Hospital, Seth GS Medical College, Mumbai. She's the director, Surya Fetal Medicine Center, Mumbai. And with lots of awards and honors and achievements, but her main area of interest is as an obstetrician with super specialization in fetal medicine and intervention. And that goes a lot in speaking about her expertise in delivering today's talk. Over to you, Dr. Vandana.
Thank you so much, ma'am. I'll share my screen. Thank you so much, ma'am, for the introduction. How I will go through is today is on anomaly scan, what next? So we know everybody who's here sitting and listening to us is obstetrician. So yes, one is the diagnosis. Second is once we make a diagnosis,
what do we do about it? So our main concern is when we diagnose a problem, what we have to do about it. So I take you through in the next half an hour on certain cases and the diagnosis and what came out in the end. So we know the statistics, huge numbers, and of all of them, India is at a huge level. This is what India is at, almost a very high number, second in the world. And the way we look at is that all the guidelines, especially the ISWA guideline, has come up with the first trimester screening, a second trimester, mid trimester, and now with the late trimester scans also. So we do pick up a lot of anomalies in the first trimester, which Jaya has already spoken about. And the third trimester, while we look at Dopplers and growth, we also look for anomalies at that time. But what I am going to take you through is this mid trimester scan, which is a scan which is the most important between your 18 to 24 weeks, where if we missed a dating, we could still do a dating here. We look at anomaly, we also look at the cervical length for preterm, do a fetal echo, look at the heart, and also we could do a Dopplers for preeclampsia if we've missed it in the first trimester. So this is the most important scan that we have. And by the guidelines, it is to be done between 18 to 24 weeks. It has increased to 24 weeks, especially for India. It is good because our MTP Act has come till 24 weeks. So there is a basic standard requirement, which you can see here by the ISWA, where you look at the head and all the parts of the head, the face, neck, thorax, heart, abdomen, spine, limbs, and the gender. So we do look at all of these things. And then if we have a problem, then what do we do about it? So patients come to us with a lot of expectation, a beautiful baby will be seen, and then we find an anomaly is where the difficulty comes in. So when we have a diagnosis of an anomaly, we first have to prepare the parents for what is coming through. We sometimes will need to look at the rest of the baby for any other malformation, look for IUGR. If it is something which is very bad, we would think of termination, and for late, we might need ethical and legislative issues which have to be sorted out. They may require a genetic testing, which if it has to be done, we do an amnio. Or if it is something which has to be managed and we can take it till term, then we would know where to deliver them, how to deliver them, where do we deliver them, and we might need a in utero transfer. So in this case, we may sometime resolve to some kind of medical therapy and surgery, which I am not going to take you through, but maybe some other day we'll do that. So for improving the outcome in these babies which have got a birth defect, we will need a team. We'll need a team who will all talk the same language. All of us will speak the same language, and the patient has to be told about what is that anomaly, what are the results, what are the survival, the long-term survivals, and also the finances which are involved with that. So if I take you through as obstetrician, all of you, that what we are concerned is it lethal? Is it severely morbid? Will it worsen antenatally? Will it resolve antenatally? And whether it can be corrected by some means in utero, and is there something which comes up evolving later on? So something like these are anencephalies and encephalocele and large neural tube defects are lethal. We know they are lethal. There's this pentology of Cantrell, definitely lethal, needs a termination. Highly morbid, huge open neural tube defects, microcephaly, again, which are highly morbid, needs a termination. But there are a lot which are not so. So 2% of the population have these malformation. So first you establish the diagnosis, be sure it is that, and it is not associated with any other abnormality, or it is associated with an abnormality, both ways. Then if IUG are there or not there, then we look at whether we do a genetic test or an infection test in this patient, whether it's lethal or highly morbid. Is it compatible with life? Does it need a termination? And as I said, then if we are continuing pregnancy, we want to know where, when, and how to do. And also we need to address the recurrence risk in next pregnancy in case we are terminating this pregnancy. So I will go through various systems one by one. Let us look at the brain and the head. We look at the size, shape, and integrity of the cranium and the density of the cranium. And we also look at these three planes, the transthalamic plane, which is a BPD plane. There are standards which have to be seen, a transventricular plane, which we have to do measurement at the level of the parieto-occipital sulcus, and the cerebellar plane where we measure the cerebellum, the nuchal fold, and in all of them we look at the CSP. So when we look at brain, I thought I'll look at my own data, and we saw that around 15% of all our cases were brain abnormalities, of which the highest was a neural tube defect. So let me show you some brain abnormality. As obstetrician, when we have a brain abnormality, there may be different presentation. So let me start with the one where it was looking very highly morbid, but once we made a diagnosis, we could help the patient. 40 years old, IVF conception, 29 weeks, FGR at first centile. She's a doctor herself, an endocrinologist, and IVF 40 years. The Dopplers are showing high resistance in the umbilical artery, but the uterines were normal and severe FGR. So our worry more, because the uterines are normal, is for some kind of a genetic problem or infection. So an amniocentesis was done and CMV was positive. You can see the PCR is positive for infection. So we know she has got a CMV infection. The cause is IUGR is CMV infection, could prognosticate. We could tell that it may be very bad, but she said, I want to do the best for this. So you please take me through till however we can. So absent diastolic flow, the ductus was still normal. And as what Sujit showed, we waited till umbilicals became reversed and the ductus became reversed. And you can see the baby was not growing very well. And we have a 650-gram baby at 32 weeks of gestation, taken to an NICU, which my NICU can save even a 500-grammer with less morbidity. But here it was a CMV infection, so was started on valacyclovir, then a shunt was put in, and then laser was done for retinopathy. Baby was in the nursery for almost 4 months and is now doing well. So here the diagnosis was a ventriculomegaly to start with an IUGR, and this was a CMV infection. Now let us look at another disorder where she was sent with a cyst in the brain. So this cyst looks like a midline cyst at around 34 weeks of gestation. And if you put on color, it's a vein of Galen malformation. Now this vein of Galen, if we leave it like this and take it till term, it may cause problem. The problem is more in the heart rather than in the brain. So there was a cardiac overload and there was this tricuspid regurgitation. And so here we had to have the whole team ready with us, because you can't deliver a baby and not have the team ready with you. And here we required a intervention radiologist who's going to do a embolization of this vein of Galen. And this was done and the baby did well. So you need to have it in utero transfer to a place where you have everything ready in the same complex. Now let us go on to one evolving disorder. Again, a patient, Primea gravida, 33 weeks, highly educated couple, and with ventriculomegaly sent to us. So now ventriculomegaly is not a diagnosis. We need to look at what is the cause, and the CSP was not seen, and you will need to do a urosonogram, and you can see there is no corpus callosum seen. So this patient was diagnosed at 28 weeks with microcephaly, but the obstetrician said, oh, it is just a smaller head, take more protein, it will improve. So that doesn't happen. So you have to look at the etiology, and here the etiology was this corpus callosum was not seen. In addition, there is also sulcation problem, and so this was a diagnosis of a Miller-Decker syndrome. And this was done, and sampling was done at almost 32 weeks, and we got a report by 36 weeks of gestation. Patient went to medical board and got a termination at 36 weeks. Now, the problem was at 36 weeks with a good sized baby, the baby will come out alive. And so we had to do a feticide, and you can see how the baby is all full term 3 kg plus baby and has got a problem. So here the diagnosis is helping us, one, that there was a severe morbidity, and second is the recurrence risk. So that Miller-Decker in the parents does not have any genetic abnormality. So it was de novo, and she has now delivered a normal child in her next pregnancy now. So other disorders like neural tube defect, large, huge open neural tube defect with Arnold-Chiari malformation has got poor prognosis. A big, huge encephalocele like this, not diagnosed, cannot happen, not acceptable for in this era. So now from the brain, I'll show you some face abnormalities. And in face, we look at both the orbits. We have to look at the lip. We have to look at the median face profile, and also look at the mouth and the palate also. So here we have a patient who was sent for a screen positive trisomy 21 and NIPT low risk with a cleft lip. So this cleft lip has been diagnosed by us and there was nothing else. So if we do an amniocentesis, the microarray was normal. She also had a cleft lip palate in her previous pregnancy where the baby died. So it was important to do this genetic test and it was normal. And so we could reassure her. Now, do we get the maxillofacial surgeon involved and the neonatologist involved? Antenatally, yes, definitely, because we need to counsel them that the prognosis is very good, but that she will require the breastfeeding techniques and the positions, and she will need a whole multidisciplinary management, which has to be sorted out antenatally itself, and then maybe go on with the pregnancy. So another face abnormality is a binder's face. Is very common nowadays. We are picking this up, but this is not something which is very bad, and it is not a disease. It is a phenotype where we look at the angle, and if this angle is more than 140, we would think that there is a flat nasal bridge. The nasal bone is there, the bridge is small. And here we have to have a system to work on. So make a diagnosis, look at the rest of the baby, do a genetic test, and then whether we continue or we terminate. So we do this in 5 steps. And here in this baby which had this binders, there is also this stippled epiphysis seen, there is calcaneal calcification seen. And in addition, you also had this spine which is showing a calcification in the end, which is telling us it is something called as chondrodysplasia punctata. So not look at the face only and say, okay, this is face abnormality. This is something not for termination also, because the genetic report all came normal. There was a VOUS, so this baby went on till term and the baby is doing well. So now from the head face, we come to abdomen, and in abdomen, we look at the stomach, the situs, look at the aorta, IVC, portal vein, and then we also look at the cord insertion. And posteriorly, we look at both the kidneys and also measure the pelvis in them. So now let us look at abdomen and see for all the GI disorders. So you may have a block in the esophagus, you could have a block in the duodenum, a jejunum, or lower down in the large bowel also. So the level of obstruction is different and they present at different time. So an esophageal atresia will present early, the poly will happen early, and the diagnosis will be early. While something which is lower down like a jejunal or a cloacal will not present with poly at all, and they may later present only near term in pregnancy. So here you have a patient at 18 weeks. I said esophageal atresia, stomach is not seen. Rest of the baby looks normal. There is some poly, but not very bad poly. So when you don't see a stomach, I'm worried. It could be a CDH, the stomach is in abnormal position, or there is a cleft lip palate. But most common of all of them is a TE fistula or esophageal atresia. So here, how will you look at is you will look at this esophageal pouch sign, which causes a distension in the level of the pharyngeal pouch, and that will give us the diagnosis of tracheoesophageal fistula. So here, one, yes, we need an amniocentesis. Second, these will present with severe polyhydramnios, and because they have polyhydramnios, they will have preterm labor. So you have to be ready for that AFI of 30, and so an amnio reduction was done, and also steroid was given, and we would want to plan a delivery near term so that this baby can be operated upon at birth. So the obstetrician and the pediatrician already knew there is a TE fistula. You can see that coiling of the infant feeding tube, and the baby was operated upon and did well. Again, here there is a baby with a double bubble sign. So you see there are two bubbles which are seen and they're communicating with each other. So this is a duodenal atresia, and there is a regurgitation, one blue and then red, which is telling us there is an obstruction. And so this is a duodenal atresia. The problem with duodenal atresia is one, it diagnosed late. Second is associated with trisomy 21. So look at the heart and you see there is a VSD also seen, and there is polyhydramnios, and the diagnosis is late at 30-31 weeks. So yes, even at that time, amnio was done, and here you could see the baby had trisomy 21. Now the ethical issues of whether we should operate on a trisomy 21, whether they want to continue pregnancy. This was at a time when medical board was not there, and so she was allowed to continue and was operated upon. So again, bowel abnormalities are later on, are jejunal ileal, when you see multiple bowel dilated loops which are seen here. Here the problem is not chromosomal. Here the problem is cystic fibrosis, and they have a high chances of meconium peritonitis and malrotation. So follow up these bowel, and you will have to see that they are not causing a meconium perforation. And so this again, baby was operated in a tertiary care center and was operated and did well. So now let me come on to cord insertion side. So we look at the cord insertion always at the level of the umbilical arteries, which are going on both sides of the bladder. And here we are more worried about omphalocele. There could be a gastroschisis, the bladder extrophy, and also limb body wall complexes, and posteriorly maybe a sacrococcygeal teratoma. I put it in the same group. So here you have a primary gravida, the whole liver is outside, and the portal vein also, and there is also a single umbilical artery. Again, association is with chromosomal abnormalities, but here the microarray came as normal. So we would follow them up, look at the liver, how much it is coming out, and a cesarean nowadays is said to do because of giant omphalocele. What do we call giant is if 75% of liver, or if the defect is greater than 5 centimeter, they will require a cesarean section. So here this baby really, because it was 3.54 kg, we had to do a section and look at the huge omphalocele. But even such a huge omphalocele does well and was operated upon. Again, a patient with 3 abortions. She came for a termination, but you see there is all this gastroschisis, the bowels are floating, there is no correct membrane over that, the cord is on one side. This usually doesn't have a genetic problem. The problem is only the gastroschisis, and you look for IUGR follow-up. So this babies, again, you have to look for any gangrene, for any obstruction, and follow them up. These babies do well. And here you can see this baby had a huge gastroschisis, the bowel is all out, but operated and did well. Problem with anterior abdominal wall defect is this bladder extrophy, where the bladder is not seen and it looks like an omphalocele. Here the morbidity is high because there is a bifid pelvis also, and the morbidity is slightly higher than a routine omphalocele. Another one is a sacrococcygeal teratoma. See, it's huge teratoma, which causes polyhydramnios, causes a cardiac dysfunction, cardiomegaly. But if operated at the right time, then we could operate on this and look at those beautiful hips that the baby has now, and operated upon and did well. Unfortunately, things like this also come up. You see, this is a huge omphalocele, which was IUFD at term, and then the fetal tissue was tested and it was trisomy 21. Should not be allowed in nowadays modern obstetrics. Now let us come on to the kidneys. And in kidneys, we look at the pelvis in this AP diameter and also look at it on the coronal plane. So in this, we usually look at is obstruction. So posterior urethral valve, PUJ, then VUR, and sometime even ovarian cyst. So we measure it at this level. We look at it in coronal level, and we also look at the renal vessels, which are going to tell me that the kidneys are present in its normal position. So nowadays, we don't call it as hydronephrosis, we call it as UTD classification. And if it is 4 to 7, we call it as grade 1 before 28 weeks, and 7 to 10 if more than 28 weeks, and nothing else is there, we call it as UTD A1. And anything more than that, we call it as UTD A2-3. So for any kind of obstruction, the same language is followed. So here we have a patient, she came from Dubai. There was a pelvic testis of only 6 millimeters, so called as UTD A1 in Dubai. And she was reassured, oh, nothing is going to be a problem. This is just 6 millimeters, usually resolve. Yes, it resolves, but we need to follow it up. She was not followed, and at 29 weeks, she came with this huge, both kidneys are hydronephrotic and calyces are dilated. So it is like grade 3 and UTD A23, and there's a dilated urethra and a distended bladder. She came here for a shunt, but because she was already 29-30 weeks, we followed her up. We did not do the shunting, not required at 29-30 weeks, and we could pull her till around 34 weeks of gestation. By then, the ureters had become hugely dilated. The kidneys were also, the cortex had become thinned out. But then the baby was born at around 34 weeks, 2.5 kg, and surgery was done, fulguration of the PU valves, and the baby did well. So you don't need to always terminate, don't have to always do some intervention. You can just masterly follow them up and can take them near term. Here you have an ovarian cyst, which we saw, so you have to look for everywhere else. Where is this mass coming out? About 5 centimeter in size. So here you have to look for torsion, and was delivered at 40 weeks. And the CT actually did not say anything, but on ultrasound, again, we saw that, and there was no vascularity. So there was a torsion in the ovarian, in the small child, and the oophorectomy had to be done in this patient. Last of all, we come to thorax. I'm not taking heart because it's a big time, and I will have only about 10 more minutes. So we have either a CPAM or CDH or a pleural effusion, which are the commonest ones. So here you see this huge white echogenic mass. It is squashing the heart to the other side. So this huge mass is a CPAM, which is congenital pulmonary airway obstruction. So here we look at the CVR. That is the size of this abnormal lung. If it is more than 1.6, they are associated with hydrops or mediastinal shift, or if there is a large dominant cyst. So you could do an expectant management. There is some role of giving steroids to them, and they commonly resolve. So that same patient which we saw so bad is the same patient here. The lungs are looking beautiful at 33 weeks. It has completely resolved. The heart has come to the center, and we delivered her in COVID ward during the COVID time, and she did not require any surgery. So such huge masses also can completely resolve. But on the other hand, this is again another CPAM where you see a huge dominant cyst. These are the ones where you can have hydrops. It's huge cyst. So we followed this up. She's 28 weeks. We could think of putting in a shunt. So we waited for some more time to see what happens. And yes, they developed polyhydramnios. It became more huge. The Dopplers were okay. Poly was there, and hydrops were starting. So here we really did put in a shunt here. So there is, in the middle one, you can see that shunt inside, and which was aspirated, and then the lung looked better. But this is only for the time in utero, but after birth, it had to be operated again, and a lobectomy was done, and the baby is doing well. So CPAM can resolve completely. They can remain same, or they may require a surgery postnatally. Similarly, a CDH is something where you will see a mediastinal shift like how you had in a CPAM. Here, the stomach is looking normal in normal position, and only a little bit of small bowel has gone up, which has caused this mediastinal shift. So here, what we look at, as we look at CVR there, we look at the LHR here. And if the LHR is good, it is left-sided. It is late diagnosis. If there is less polyhydramnios, they will do well. So LHR has to be looked at. And in this patient, the advantage of diagnosis is that the team is ready. It doesn't have to be bag masked. It has to be intubated immediately. So a 3.2 kg baby was born, immediately intubated, stabilized, and operated on day 3, and the baby did well. So CDH is something which is the most important pediatric medical emergency, which has to be intubated immediately. So now looking at this is an ortho professor's wife, where there was pleural effusion on both things. There was nothing in the abdomen, only isolated pleural effusion. So we thought, let us do amniocentesis to look for a genetic problem. And same time, we also did a aspiration of the pleural fluid. So we thought maybe we aspirate, the baby will become better, but we sent for all the genetic testing. So in 3 weeks, when the reports came, infection was normal, genetic was okay, the chromosomes were okay, but yes, it came out as Noonan syndrome. So this was a disorder which was diagnosed, and it is an autosomal dominant disorder, has got poor prognosis, and by that time we saw that the pleural effusion had formed again. So no use of doing a pleuroamniotic shunt here because the diagnosis is of Noonan. So whenever we do any medical intervention, we need to be sure that it is required and it is rightly done. Last of all is this skeletal abnormality. Previous 2 LSCS, 2 babies, both one had died, one is alive. And then now this patient, earlier scan done somewhere else, was looking perfectly normal. And at around 32 weeks, you see the femur has become very, very small and all the long bones are small. So when you have a short long bone, it could be IUGR, but it is not because the AC is good. The Dopplers are normal. The growth of the dominant head is good, but the femur and all the long bones are small. So it is telling us there is some kind of a skeletal dysplasia. There is a frontal bossing. The bones are all small. And in addition, there is this angle we look at. If there is an obtuse angle, it is more specific of achondroplasia. So we did an amniocentesis at almost 33, 34 weeks. The microarray was normal. And yes, what we thought achondroplasia, it is an autosomal dominant disorder, again, had to go through termination through medical board, which first the medical board did not allow because it is a non-lethal abnormality. Then they went to court, and from court they got a termination order, and we could do her termination at almost at 38 weeks of gestation. Last of all, just few cases. Here you see a conjoined twin. This is an anomaly which is picked up at around 20 weeks, but because the parents wanted to continue and it looks like it is only the liver which is fused, we also help them to continue this pregnancy. What monitoring to do in a conjoint is not written in guidelines. So we just monitored the umbilical artery and the MCO of both the babies. Umbilical artery, they were 5 vessels, so we don't know which one had to be monitored. So now when to deliver them, 34, 36, 37, 38, again not given in any guideline. Do we do a lower segment or we do a classical, is again not given. So we gave a slightly higher incision, a little longer incision, and we dissected a little more. And then we delivered the baby one by one. So one baby's head, then the body, then rotated the baby, and then brought the other baby's buttocks and then the head last. And you can see a 4.5 kg conjoint twin at around 37 weeks, and they were 5 vessel. And then the team of our pediatric surgeon who operated for at least 6 hours to bring them out in the world as good babies. Last of all, therapy is again something when you have an anomaly, you need to sometimes do some treatments also. So here you have a polyhydramnios who came to us. The thyroid looks enlarged and vascular also. And she was a patient who was thyrotoxic, was on very high doses of hypothyroid drugs. And so the baby was becoming hypothyroid. So intraamniotic instillation of thyroxine can sometimes be done to take care of this baby. Again, here you have a baby who has got supraventricular tachycardia. If we leave it like this for a long time, they will develop hydrop. So if it is persistently like this, then you may need to give them flecainide or digoxin also for these cases. And you can see here the same baby, the rate became all right after giving her flecainide. So one isoimmunization is something which is the best treatment which is available for our babies in fetal medicine. When we look at the middle cerebral artery velocity, and if this velocity is high in an ICT positive patient, then we need to do transfusion. And when it reaches 1.5 mom, we need to do a transfusion. So we had this rare case of a triplet, 3 babies, 1 neonatal death. So these triplets were monitored, taken till 28 weeks. And at 28 weeks, they all 3 became severely anemic. So we had an option, either we deliver all of them at 28 or do a transfusion for all of them. So we did a transfusion of all the 3 triplets, and all of them required 70, 60, and 50 ml of blood. And then we could pull on for 5 weeks more and reach 34 weeks. And she had to be delivered for preeclampsia and help, and not because of the anemia. And these babies, we earned 5 weeks, and we could earn these 3 babies for us. And this is the world's first triplet transfusions which have been done here in India by us. And the British Journal of Case Report have recognized it as the world's first. Last case, this is again a difficult case. You had a huge pleural effusion. You can see the heart pushed to one side, and there is a huge mass. This huge mass was having the supply from the aorta. So it was a pulmonary sequestration which was causing the hydrops. And you can see even there is scalp edema, there is pericardial effusion, there is pleural effusion, and there is hydrops also seen. So at 28 weeks, we thought, let us try and put in a shunt here. So here you can see we are putting in a shunt here into the pleural fluid, but yes, it improved it for some time, but then it filled up again. So it was filling up again because the shunt was not working, because this was the vessel which was causing all the problems. So either we could have done a laser, but that was a time when these lasers were not available. So we decided to do an exit procedure. So we aspirated, and on the table we did a cesarean section, and then the baby, before the lungs could be taken out, was incubated and an exit procedure was done. A 1 kg baby was born with hydrops, and then this was operated on day 8 of life. This was a huge mass that was there, and the baby was stabilized. You can see the x-rays have improved, and again this baby doing well. So this is again the smallest neonate who was antenatally diagnosed, antenatally managed, and then postnatally smallest baby to undergo a surgery and survive. So I showed you all these cases for you to understand that anomaly scan is very important. It needs to be done both in the mid trimester and relook at it in the third trimester during your Dopplers and your growth scans. It will help us in diagnosing anomalies, and some which are undiagnosed to be diagnosed later on. It helps us in monitoring these abnormalities in utero transfer, timing of delivery. Multidisciplinary team has to be made ready. Sometimes therapies are required, and sometimes legal terminations are required, so that when we have this abnormality, the parents can be help throughout, so that they could have a good perinatal outcome. So I would stop at that, and I am open to questions if there are.
Thank you, ma'am, for such an elaborate presentation. And I'm sure that the delegates would have a very good take-home messages that no anomaly should, which can be treated, should be advised termination. We can always give them an option that this treatment facility does exist. And if they are affording, then we should opt for it. Thank you so much for the message, ma'am.
Thank you.
Yeah. Can we have our next speaker slide, Dr. Suma Vishnu, please? Madam is going to speak about specifically Leica abnormalities which are associated, and the anomalies that are associated with it. Madam holds a fellowship in advanced obstetrics ultrasound from Mediscan Systems, Chennai. She's a consultant at Vinayaka Hospital, Wayanad, Kerala. The founder treasurer of the Wayanad OBGYN Society, member of the Perinatology Committee, FOXI, member of the Clinical Research Committee, FOXI, and district coordinator for the Mission Pink Health at Wayanad. We welcome you, ma'am, and we request you to please start your presentation. Suma, ma'am?
Yes, I'm here. Good evening, everyone. Hope I am audible.
Yes, ma'am, you are.
Yeah, thank you. And first of all, a big thanks to Patel sir, my friend Dr. Monica, and my co-speakers, Dr. Vandana madam, and all the expert speakers of the team for this wonderful opportunity. After a very, very elaborate talk by Vandana madam, I am just going back to the basics of ultrasound, something which we have to see along with the baby, and something which has very much importance in when we do an ultrasound from as early as 13 weeks of pregnancy, and that is nothing but Leica anomalies. So my talk for today is anomalies related to Leica abnormalities. So just going back to the basics. Hope my slides are visible. So amniotic fluid, as we all know, it is a water-like substance that surrounds and protects the fetus during pregnancy. And it definitely protects the umbilical cord by reducing the risk of compression between the fetus and the uterine wall. So it protects the fetus from infectious agents due to its inherent antibacterial properties. So it is not just a fluid, it is actually a reservoir of fluid along with nutrients, which serves the fetus, and it contains proteins, electrolytes, immunoglobulins, and vitamins from the mother. And it provides necessary fluid, space, and growth factors to all the normal development and growth of all the fetal organs, such as GI tract, the musculoskeletal system, lungs, the pulmonary system, and everything. So liquor is something which is as important as fetus once the fetus is in the womb. So just brushing upon the basics, because we need to know how the liquor is produced and how the liquor is secreted and how it is absorbed. Then only we can assess what all things we have to see when there is an increase or decrease in the volume of the liquor. So regarding the development in the early gestation, from the start of gestation till 8 weeks, the liquor is derived from the fetal and maternal factors such as water from the maternal serum, coelomic fluid, and fluid from the amniotic cavities. And after 8 weeks or in the late gestation, it is largely produced by the fetal urine and lung secretions. So that is very important. So any abnormality in any of these stages can cause a difference in the volume of the liquor. So regarding the production in the early pregnancy, as I already told, it is usually formed from the maternal plasma, and it passes through the fetal membranes via an osmotic and hydrostatic pressure, and then it moves across the fetal skin. That is the transcutaneous flow. In the second half, fetal urine and lung secretions, that forms the major chunk of fluid or the amniotic fluid. The fetal urine production, it becomes a major contributor around 8 to 11 weeks of pregnancy. And by term, the fetus can produce a volume of almost a liter of urine, 1 liter of urine per day, and that adds significantly to the amniotic fluid volume. And along with the fetal urine, lung secretions also contribute. So how does this amniotic fluid circulate? It is produced from the urine and the lung secretions, and also from the transcutaneous flow through the fetal skin. And how it is absorbed? There are 3 main ways of absorption or circulation of amniotic fluid. The first is fetal swallowing, second is the intramembranous pathway, and third is fetal respiration or the pulmonary route. So by swallowing, the fetus swallows the fluid and it is absorbed in the fetal gut, and that is the major elimination pathway for the fluid. The second is the fluid is also absorbed directly from the amniotic sac into the fetal circulation. That is through the vessels in the placenta. So that is the intramembranous pathway. And the third is the fetus circulates through the fluid along, that is through the pulmonary tract, and that also aids in lung development. So these are the 3 ways in which the amniotic fluid circulates in the fetus. So this is in a nutshell. Inherently, the liquor is produced as fetal urine and the lung secretions, and the circulation, it happens through swallowing, intramembranous pathway, and transmembranous absorption. So these are in a nutshell how the liquor is getting circulated in the maternal womb. And this is also the same thing. By swallowing and absorption through the respiratory tract, the liquor is getting into the fetus, and from the fetus is going out as urine, and it is transferring across the chorionic plate, and placenta also has a major role in the amniotic fluid circulation. So how will we assess, or what are the tools we use to assess the liquor volume once the fetus is in the womb? As we all know, it is the AFI or the amniotic fluid index, or it is the maximum vertical pocket measurement. Why I am highlighting this part is that whenever we get a report as AFI 5 or AFI 10 or AFI 12, we are initiating the treatment as per our reports. So it is very important that the AFI or the MVP is measured in the right way. That is very important because all our treatment depends on the report we receive. So AFI or the amniotic fluid index is measured in a way like we divide the uterus into 4 quadrants, measure the deepest pocket in each quadrant without fetal parts and without cords, and we take the sum of the 4 quadrants. And maximum vertical pocket, it is the only single deepest pocket of fluid that is measured, and we take it as the MVP. And both these methods involve scanning with the transducer held perpendicular to the fetal abdomen. That is very important. We have to keep the transducer in a very perpendicular position to the abdomen. If we tilt the transducer, we can get a false, wrong, or a wrong value of oligo or polyhydramnios. So that is also very important. We have to get the deepest unobstructed pocket of LICA or fluid in centimeters. So regarding the maximum vertical pocket, as I already told, scan the entire uterus. Initially, see the whole uterus and locate an area of single deepest pocket of amniotic fluid. Measure the only vertical depth of this pocket in centimeters. Make sure that it is free of fetal parts or any cord in it. And the normal range is 2 centimeter to 8 centimeters. So this is how the maximum vertical pocket is measured. And AFI, I already told, we divide the whole abdomen of the fetus, whole abdomen of the mother with 2 imaginary lines, one horizontal and one vertical, that cross at the navel, and divide the uterus into 4 quadrants. Then take the deepest pocket in each quadrant without any fetal part and without any cord, and then measure the 4 measurements, that is in centimeters, and the normal range is 5 and 25 centimeters. So this measurement part is very, very important, because how we proceed and what all things we have to do and evaluate all depends on our value of AFI or maximum vertical pocket. So this is how we measure the 4 pockets. We get 4 measurements, and all our ultrasound, they themselves will calculate and they will give an AFI for us. So coming to my first case scenario, a 20-year-old lady, she presents at 22 weeks of gestation with a single vertical pocket of 8.5 with growth of the fetus appropriate for gestational age, and the patient is referred for an expert opinion. So this is polyhydramnios. So it is an excessive volume of amniotic fluid relative to the gestational age. The polyhydramnios can be acute or chronic. So acute is something which is getting collected in a very fast way or in a very quick process with the fluid accumulating over few days. But chronic polyhydramnios, that is what we usually encounter. It is a very gradual process, and it occurs in a gradual time, and it usually presents in the 3rd trimester. And the incidence is 0.3 to 1.6%, even though the incidence is not that high. If you get a case, definitely we have to go for a very systematic evaluation. So once you get a polyhydramnios with a fetus in it, so what all things we have to see for? So the first thing is that we have to go for a maternal evaluation. And the commonest thing we encounter with polyhydramniosis, as we all know, it is maternal diabetes. Either it is an overt DM or a gestational diabetes. So we have to definitely go for a glucose tolerance test if there is associated macrosomia. If there is no associated macrosomia, also we have to rule out diabetes to the mother. The second thing is that we have to go for a TORCH test. We all know about TORCH. It is a panel of fetal infections, and it is suggestive and to rule out that there is no features or fetal features of TORCH infections. The third thing is that we have to go for an RH typing and evaluation if we are suspecting an isoimmunization, and definitely the drug history. Some of the drugs like lithium, ACE inhibitors, even in this era, we have to ask for substance abuse too, because many of the women may be a part of it. So we have to specifically ask for all these things again and again. Sometimes they may not be telling us. So we have to seek or ask for the drug history also to know that whether there is any association. And the next important thing is that there should be a detailed ultrasound examination. We have to go for a very systematic anomaly tracing examination of the fetus to see for any associated anomalies of the fetus. And the third part is that the invasive testing. So if everything is okay, we don't know what is the cause, then as Vandana madam told in the previous case scenarios, we have to put a needle and take out a sample of LICA and go for a karyotyping and array. If there are fetal abnormalities or growth restriction, then we have to go for a DNA testing appropriately and see for any associated genetic associations. So the most common reason for polyhydramnios, the absorption of LICA is not happening. So the commonest reason may be a reduced fetal swallowing. As I already told, fetal swallowing is one of the way in which LICA is getting absorbed into the fetus. So the most common causes are brain abnormalities, GI tract abnormalities, compressive pulmonary disorders, and fetal echinacea deformation sequence. So the brain abnormalities, as we all know, anything like anencephaly, Dandy-Walker malformations, any facial tumors which can hamper fetal swallowing can be associated with polyhydramnios. And GI abnormalities like esophageal or duodenal atresia, as we saw in the case scenario in the previous presentation, and small bowel obstructions. These things can present with polyhydramnios. So once you see that the liquor is on the higher side, definitely a thorough evaluation of the face, CNS, GI tract is a must. Then you go for the chest examination, and if you see that if there is any compressive pulmonary disorders like pleural effusions, diaphragmatic hernias, CPAM, CHIOS, anything or a narrow thoracic cage due to skeletal dysplasias, even it can be a reason for polyhydramnios. And if you feel that structurally everything is okay, just see for any fetal echinacea which is happening. It can be a part of a neuromuscular impairment of fetal swallowing. So watch for the fetal movements, whether the fetal movements are appropriate for that particular gestational age. So we have to have a thorough anatomical screening of the fetus and specifically see for these areas to make sure that there is no anomalies associated. So these are the images, the anencephalies, the tumors, the facial tumors, the cleft, huge cleft which is there, anything which can hamper the GI anomalies like the double bubble sign. Here you can see the intestinal obstructions. All these things can be associated with polyhydramnios. Here we can see compressive pulmonary disorders like a CPAM, congenital diaphragmatic hernias, or a CHIOS. Anything can be associated with polyhydramnios. So once you screen anatomically the fetus, please see specifically for these disorders which can be correlated with polyhydramnios. The second reason, so one thing is reduced fetal swallowing. The second thing is if the fetal urination is increased, then also the liquor can be on the higher side. So what may be the reasons for an increased fetal urination? As we all know, the commonest cause is maternal diabetes mellitus or maternal uremia. Because of the increased glucose load and urea, that can cause osmotic diuresis, which can cause an increased urinary output to the fetus. The second thing is that fetal anemia. Fetal anemia can be due to isoimmunization, or it can be even due to congenital infections like parvovirus. Once a fetal anemia occurs, there can be a hyperdynamic fetal circulation. Even it can lead to cardiac failures and increased urine output to the fetus and polyhydramnios. And the third thing is any fetal and placental tumors like sacrococcygeal teratomas, placental chorioangiomas, which can increase the transduction, the flow from the placenta, the fluid leakage from the placenta, and increase the liquor volume and can cause polyhydramnios. And definitely twin-to-twin transfusion syndrome. As we all know, there can be a poly-oly sequence. So impaired fetal swallowing and increased fetal urination. These two things are the crux, or these two things can be the reason behind the polyhydramnia. So we have to have a systematic approach to the ultrasound once you see increase in the liquor volume. So definitely not only the fetus, we have to see the placenta too. As I already told, there can be placental tumors like chorioangiomas, circumvallate placentas, which can be associated with polyhydramnios. So as I already told, just in a nutshell, multiple gestations. If you are looking into multiple gestation, rule out twin-to-twin transfusion syndrome, or you rule out if it is a singleton or multiple, you rule out anomalies like GI, CNS, skeletal malformations, and fetal tumors. These four are very important to check for and to rule out once you get a case of polyhydramnios. And once you have ruled out all these things, is there something else which we have to see for? There is some rare causes or some not often found causes like cardiac disease of the fetus, like fetal arrhythmias. A severe fetal arrhythmias, especially a SVT or an atrial flutter, that can lead to a poor cardiac output of the fetus. This inefficiency can cause fluid to accumulate in the fetus and the surrounding amniotic sac. So a fetal arrhythmia can also be a causative factor of polyhydramnios. If that is also okay, definitely screen for genetic diseases, genetic syndromes like Downs, trisomy 13, 18, multiple congenital anomalies, myotonia dystrophica, all these genetic syndromes also. Please keep on the back of your mind once you screen for the fetal polyhydramnios. And there are some rare endocrine disorders also, renal and endocrine disorders like vasopressin insufficiency of the fetus, or even a hematological disorder like a homozygous alpha thalassemia, or a huge fetal-maternal hemorrhage which is happening, which is causing fetal anemia. So once anemia occurs to the fetus, the fetal heart works harder to circulate the reduced number of RBCs, leading to a high output cardiac failure. So once baby is in cardiac failure, that can cause excessive urination of the fetus, which indirectly can be a reason of polyhydramnios. So these are all things we have to see once you see a case of polyhydramnios to rule out what is the etiology, or to, before labeling it as an idiopathic polyhydramnios, we have to rule out all these things. So what is the risk of polyhydramnios? As we already discussed, there can be a chance of preterm labor, PPROM, and maternal discomfort, dyspnea because of the over distension of the uterus. And even during delivery, there is definitely a chance of umbilical cord prolapse, and placental abruption. And after delivery, because of the over distension, there can be PPH, fetal malpresentations, and increased risk of C-sections and instrumental delivery. So all these things we have to keep in mind once you send the patient, or once you have a patient with polyhydramnios in labor. And what all prenatal therapy you can do once you detect a polyhydramnios with a specific etiology. If you see that the mother is having diabetes mellitus, definitely a good glycemic control is very, very important. And if there is any features of dysarrhythmia, then antiarrhythmic medicines can be given to the mother, can be instilled into the fetus, and that can also help in reverting the polyhydramnios. And fetal anemia, as we heard, definitely intrauterine transfusions can help a lot. Then cyst and effusions, transthoracic amniotic shunting, twin-to-twin transfusion, laser occlusion of placental anastomosis can be done. So depending upon the etiology, we have to get a proper treatment to the mother so that the fetal morbidity and the prematurity is reduced. And if there is a fetal tumor or a placental tumor, then laser occlusion of the feeding vessel can help a lot. Then defects, if it is resulting in reduced fetal swallowing or severe idiopathic polyhydramnios, then we have to definitely go for amnio drainages. So we have to go for serial amnio drainages and make sure that she is not going in for preterm labor. And a role for indomethacin, definitely it is an effective method, but we have to keep in mind that it can cause a premature closure of ductus. So a serial echo monitoring of the fetus is also warranted. So all these things we have to do once you get an etiology, or once you go for the evaluation and management of a case of polyhydramnios. So if you get a antenatal mother who is having polyhydramnios in labor, we have to go according to the standard obstetric care and delivery in most of the cases, and induction of labor at 38 weeks of gestation with an ICU care and facilities for pediatric surgery if indicated. And with regard to the fetal tumors, as we already heard, we can go for an exit procedure, or if any concerns, then we have to go for a cesarean section also. If you have severe polyhydramnios, the most important thing is that you have to prevent cord prolapse. So a controlled induction and a controlled membrane rupture is very important, and active management of third stage of labor to prevent PPH is also a must. So all these things we have to keep in mind once you have a mother with polyhydramnios in labor. So coming to the other end of the spectrum. So you have a 28-year-old primea gravida who is coming to you at 20 weeks for an anomaly scan, showing all growth parameters corresponding to the gestation and single vertical pocket less than 2 for further evaluation. So we all know that it is definitely oligoamnios. So this oligohydramnios when we tell regarding the maximum vertical pocket, if it is less than 2, or an amniotic fluid index, that is the sum of the 4 quadrants, is less than 5 centimeter, we call it as oligohydramnios. So what can be the reason? As we already know, the circulation of the amniotic fluid, when you get an oligohydramnios less than 24 weeks, there are 3 major causes of oligohydramnios. The first and foremost is urinary tract abnormalities. When you get a case or a fetus with a bilateral renal agenesis, or a multicystic dysplastic or a polycystic kidneys, or a urethral obstruction, that means that the kidney is not functioning and it cannot produce urine. So the liquor is definitely reduced. So that is the one thing. Second thing is, if you get a preterm pre-labor rupture of membrane, sometimes she may have leaked out the liquor and the liquor is reduced. So fetus will be having a normal fetal growth, normal fetal Doppler, and mother will be giving a history of vaginal loss of clear and blood-stained amniotic fluid. So that is the second reason. And the third commonest reason is fetal growth restriction with Doppler evidence of high impedance to flow in the uterine or umbilical arteries and redistribution in the fetal circulation. That means that the uteroplacental insufficiency, the abnormal Doppler, that is severe IUGR and abnormal Doppler, which is causing impairment in the placental development and placental function, and that causes a reduction in the liquor volume. So these 3 are the major causes of oligoamnios at a period less than 24 weeks of gestation. So here we can see there is an empty renal fossa with a lying down adrenals, and the renal artery is not shown as the kidneys are absent. And here we can see a polycystic kidneys in this picture, and also a bilateral gross hydronephrosis with a distended bladder and a visible posterior urethra. So it is a bladder outlet obstruction. So anything affecting the kidneys, the function of the kidneys, then definitely the urine output will be inadequate, and that can be a reason for oligoamnios. So if there are no anomalies detected, then what next? So as I already told, if the fetus is structurally okay, then you have to see the placenta, and placenta can be a reason. The early onset FGR with placental abnormalities, it can be a reason for oligoamnios. The next thing is you have to see for fetal infections like toxoplasma or CMV, any infections to the fetus. The third is genetic issues, and the fourth is PPROM. So apart from anomalies, these 4 things should be in our mind once you see a case of oligohydramnios. So this is one of the not that common, but still a common thing which we see for when you see a case of oligohydramnios, that is the Meckel-Gruber syndrome. It is a combination of encephalocele, dysplastic kidneys, and polydactyly. So you have to, the key point is that you have to see the fetus structurally, each and every organ, not only the kidneys, every organ of the fetus. Here we can see an encephalocele, polydactyly, and dysplastic kidneys. And other polycystic kidney disease, autosomal recessive polycystic kidney diseases, any other genetic abnormalities like trisomy 18, 13, BOR syndrome. There are so many genetic issues which can be a reason of oligohydramnios. And once you screen for the Dopplers in early pregnancy, that is if the patient is coming to you at 18 weeks, definitely you have to look for the uterine arteries. If you get an abnormal uterine artery flow, that means that the placenta is not healthy, and that can be a reason of late onset or early onset FGRs, and FGR can be a reason of oligohydramnios. Then you have to screen for the umbilical arteries to see that whether there is any reduction in the end-diastolic flow, or whether the end-diastolic flow is absent or reversed. So any of these abnormal things in the Dopplers, in the uterines or in the umbilicals, can cause early onset FGR, and along with that there can be a reduction in the liquor volume. So that can be another reason. And definitely, as I already told, it can be a PPROM, and maternal drugs like indomethacin, AC inhibitors, NSAIDs. Sometimes we may not be knowing about the drugs which the patient is taking on herself. We have to ask them whether they are taking any drugs, then only we'll get a history like this. So that may be the single reason, may be the cause for oligohydramnios. So what is the risk of recurrence in a case of all these anomalies, that is renal anomalies? Agenesis of multicystic renal disease, there is definitely 1 to 3% chance of recurrence. And if you get a polycystic kidneys, definitely there is 25% chance of recurrence if it is an autosomal recessive autosomal recessively inherited. And PPROM, preterm rupture, it can be, there can be a 10 to 25% risk of recurrence. So patient should have a very close monitoring in her next pregnancy, and if indicated, cerclage or vaginal progesteron should be advised to reduce the risk of preterm delivery. And uteroplacental insufficiency, 10% chance of recurrence is there. So in the next pregnancy, you can advise her, depending on the uterine artery Dopplers, you can advise her aspirin 150 milligram at bedtime from 12 weeks of gestation. So that is how we can prevent or we can monitor the next pregnancy once you get a pregnancy terminated with oligohydramnios at an early gestation. And Potter sequence. So what is the bad effect of oligohydramnios if it is occurring at an early stage? There can be a Potter sequence. The pulmonary hyperplasia, underdeveloped lungs can be there, and characteristic facial features, Potter facies, due to the uterine compression because of the absent liquor, and limb deformities can be associated. So oligohydramnios at an early gestation, like 20 weeks, severe oligohydramnios, we can't continue the pregnancy. We'll have to counsel for a termination. And regarding the fetal urinary tract abnormalities, if there is a urinary tract abnormality, the standard obstetric care and follow-up and delivery at a tertiary center is advised. And if it is a rupture of membranes, then you can keep for expectant management, and you have to monitor the maternal and fetal parameters. The maternal parameters to rule out sepsis, and fetal parameters to rule out morbidity to the fetus, and in delivery by normal route, the normal vaginal delivery or cesarean section as per the obstetric indications. And uteroplacental insufficiency, there should be a very close monitoring with Dopplers, DFMC and CTG, and decide on termination depending on the Doppler parameters, the gestational age, the fetal size, and the degree of fetal compromise. So that is very important. So depending upon the etiology, you have to plan for the termination and decide on what gestation you have to terminate this pregnancy. So coming to my take-home messages, any abnormalities in LICA should be evaluated as per the gestational age of development of abnormality. And maternal evaluation is very, very important. First, we have to go for a maternal evaluation. A detailed fetal anatomical screening should be done. And the management of this entity, whether it is polyhydramnios or oligohydramnios, largely depends on its etiology and gestation. So my final word, tiny things can have a huge impact. A simple polyhydramnios can be a marker of a very big disease or a very big disorder which is coming in front of us. So keep a watch on these tiny things, and thank you so much.
Thank you, ma'am, for an elaborate presentation. It was really an eye-opener to know how many things can be associated with just LICA abnormalities, and most of the times we just prescribe arginine and we think it will take care of it. Thank you for improving our outlook towards this topic.
Thank you. Thank you, Dr. Monica. Thank you so much. And thank you for the invite. Thank you.
So now it is our privilege to move forward and invite our program director, Dr. MC Patel, sir, for delivering his talk about the PCPNDT Act. Sir has been the vice president of FOXI. Sir has been actively involved in the Northeast as well as districts for the Pradhan Mantri Seva Yatra since the last 23 years. Sir is the go-to person and an important medical legal consultant pan-India. We welcome you, sir, to deliver your talk. Before we can, sir starts, I would request all of you to please vote and support for him as the presidential candidate too. Over to you, sir.
Oh, yes. Let me share my screen. Is it seen full screen?
Yes, sir.
Yes, fine. So thank you, Monica, for kind words. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the members who have joined this society and all the faculty who have contributed their talk and spare their time to be with us in our Happy Learning Masterclass 240 episode. So thank you. And before I go to the subject, please endorse my candidature for post of President Foxy election year 2026. Nomination process is already on. So President and Secretary of respective society will have to nominate me, and it is e-nomination this time, and it is a job of only 2 minutes. So spare 2 minutes for me, and please nominate my candidature for post of President Foxy, because my commitment is still there. Wherever you are, I'll be there, promise to reach the unreached. Usually I start any of my talk with this question: is it worth discussing? Yes. If it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and we gynecologists rank first. And as far as this PCPNDT Act is concerned, there are so many litigations against gynecologists and radiologists, but gynecologists are in driving seat as far as litigations are concerned. And why this act is for? Aims and objective of that very act was to reduce gender imbalance, prohibition of prenatal determination of sex and communicating sex of fetus, prohibition of preconceptional sex selection, prohibition of advertisement of such facility by any clinic was the aim, and regulation of genetic counseling center, genetic laboratory, genetic clinic, and or ultrasound clinic or imaging center. And it is very clear that no center can function unless it is registered. So center should be registered in any category as per practice. Either it could be genetic counseling center, or genetic laboratory, or genetic clinic, or ultrasound clinic, or imaging science, but center should be registered under PCPNDT Act. So PCPNDT Act is still sword hanging and scope. So what actions are taken by appropriate authority under PCPNDT Act's provision? Application for registration is rejected. Application for renewal is rejected. Notice issued. Documents confiscated. Registration suspended. Registration cancelled. Machine seized. Court case filed. So appropriate authority may take any of these action just I mentioned. And under this act, it is cognizable offense. What is cognizable offense? Sorry. So cognizable offense means investigating officer may take cognizance of offense, and without permission of court, he may initiate the investigation. Non-bailable. Under this act is non-bailable, and bail cannot be granted at police station level, and bail can only be granted by honorable court. And it is non-compoundable. Non-compoundable means case cannot be withdrawn in between. Once case is filed, result has to come. It could be in favor, it could be against, but once case is filed, case cannot be withdrawn by appropriate authority. And ignorance of law is no excuse. So as soon as any act, any ordinance, any law passes in government gazette, it is presumed by law that each and every citizen of India knows that law. So ignorance of law can never be an excuse, because there are so many provisions in PCPNDT Act. Many of our friends do not know, and many times they could be in trouble due to that only. So be vigilant and take medical legal advice whenever you are in doubt, because there are wrong interpretation on part of appropriate authority many times, and notices are served or cases filed and machines are sealed. So which are this deficiency or inaccuracy in record in Form F is the main problem. Name of center not written properly. Registration number is not written or wrongly written. Detailed address, telephone number of patient is not written. Number of children with sex of each child not written or not written in detail. Indication for prenatal diagnosis not written or not written properly. Result of sonography not written or not written properly. Date not written. Declaration of pregnant patient is not signed. Declaration on part of doctor is also not signed. Antenatal sonography register is not prepared or not maintained properly. Delivery register not maintained properly. Doctor didn't wear apron with nameplate is also one more allegation. Board is not displayed at conspicuous place. Certificate of registration is not displayed at conspicuous place. Copy of Bare Act, that is PNDT, not available. If available, then it is not recent one. So there could be any reason, and appropriate authority may take action. So which are the prevention? Because prevention is always better than cure. And what to do? No obstetric practice. If you do not practice obstetric, then PCPNDT Act doesn't come in picture. No sonography. If you are not doing sonography, you have no sonography machine, then also you do not come in purview of PCPNDT Act. No preconceptional sex selection. It is also a very limited what we say defense, because if at all you have machine, even if you are not doing this preconceptional sex selection, but if you have not maintained record properly, then also you could be in trouble. No prenatal sex determination. If you are not doing prenatal sex determination, it's fine, but at the same time you have to keep all the records very up to date. Comply with the provisions of is very much the must, and if you comply with the provisions of law, then you could be out of problem. So what to do in this type of situation? No center can function without registration. So registration of center is very much must, and one should be very ready to start with clinic with registration only, and it is very much mandatory under section 18 of this particular act. So at the time of applying for registration, you have to apply in Form A with all requisite documents and required fees. So specify facility you apply for, because many times what happens, if you are interested to go for chorion biopsy, amniocentesis, chordocentesis, fetoscopy, fetal biopsy, but at the time of applying for registration, if you have not mentioned, and if you have simply mentioned only ultrasound, then certificate will be given only for ultrasound. So you cannot go with invasive procedure. So at the time of applying for registration, you should be sure that if you are interested to practice invasive procedure also, you have to mention in the Form A. If you are registered, registration is given to your center, then it is for 5 years from the date of issue. Renewal of registration. So before 30 days of expiry of registration, one has to apply for renewal of registration with all requisite documents, and fees. Fees will be one up. So if it is a single clinic, then registration fees 25,000, and for renewal it would be 12,500. But if it is more than one entity, then registration fee is 35,000, and at the time of renewal, one will have to pay 17,500. But many a time, appropriate authority may refuse renewal and giving reason that there is pending case before any court, because few of our friends are served with a notice in past and their machine is sealed or registration is cancelled, and in a court they are released, machine is also free, registration is also given back. But at the same time, appropriate authority file complaint in judicial magistrate first class in that very district, and this type of cases runs for years together, many a time 7 years, 8 years or 10 years, and your renewal time comes. So at the time of application of renewal, application will be rejected by appropriate authority by giving reason that there is pending case, and under Rule 18 appropriate authority can refuse. But there are few cases. Say, for example, this is one case which was decided by Honorable High Court Bombay and Branch Aurangabad. One more case in the same High Court, and this case was decided in Gujarat High Court, and one more case was also decided in Gujarat High Court. But in all those four cases, main inference held by the Honorable High Courts were pendency of criminal case or lodging of a FIR itself may not constitute ground for refusal of registration or refusal of renewal. So, if appropriate authority rejects your application, of course, you will have to prefer appeal in state appropriate authority. And before state appropriate authority, if you go with all these judgments and proper argument, then state appropriate authority will order to district appropriate authority to renew your certificate. There is one provision of deemed renewal. If there is no communication from appropriate authority within 90 days of your application, then your center is deemed renewed and no need to go for waiting from appropriate authority if 19 days are passed. But here word of caution as far as renewal part is concerned, because you have to apply for renewal 30 days prior of expiry date, and appropriate authority has also power that they can communicate within 90 days. So when you have applied for renewal 30 days prior, after 30 days, if there is no communication from appropriate authority and if they have not renewed your certificate, then very next day your center becomes unregistered. So in this situation, I always advise our colleague, whenever you are apply for renewal, apply 90 days before renewal date of expiry. So even if appropriate authority doesn't turn up within 90 days, then your center will be automatically renewed. And if appropriate authority gives registration, it is fine. And if appropriate authority rejects giving reason, then you will rectify those reason or query and your registration will be renewed again. As far as this certificate of registration is concerned, one copy of certificate is to be displayed at conspicuous place at place of business, and waiting room is the best place because maximum number of visitors will have a look to that very register. And same way, you have to display this type of board in your waiting room: name of hospital, address of hospital, and writing like this: antenatal sex determination is punishable offense and sex determination is not done here. So this type of board should be there. In certain states, government has given description that this type of board should be 3 feet by 2 feet with a blue background and white fonts. So it could be different from state to state, but whichever guideline on part of that respective appropriate authority in your respective state, you have to follow this. One more area, you should have a bare act copy of PCP and DT Act available in your hospital, and any visitor may ask that copy, and it should be in English and preferably in vernacular language. Who is sonologist? Who can do sonography? Very important question, many a time asked, and many a time sonography is rejected by appropriate authority that you cannot do sonography. And in this very public interest litigation and in RTI, it was very clear. And Supreme Court asked Government of India to clarify in 2010, and Government of India approached Medical Council of India. At that time, Medical Council was there, NMC was not there. And in meeting of MCI on 26th of December 2011, it was decided that who should be called as a sonologist. So any radiologist or obstetrician having postgraduate degree, diploma or DNB, they are sonologists. Any MBBS graduate having training for 6 months, it is requisite training and prescribed training under government, and he will have to clear exam at the end of training of 6 months. And if he can clear exam, then he will be given certificate and he can do sonography even if he is MBBS graduate. Teachers in radiology and OBGYN, they are also sonologists. So gynecologists and obstetricians also do not need to undergo any training, as ultrasound training is a part of their curriculum. It is considered by law that once they have having postgraduate degree, diploma or DNB, they have been taught sonography and they do not need any further training to avail certificate under PCPNDT Act. So they would not require any training or any certificate. So maintenance and preservation of record. It is a very important part under PCPNDT Act. Why it is important? Because under section 4 subsection 3, any deficiency or inaccuracy found in record shall amount to contravention of provision of section 5 and section 6 of Act unless contrary is proved by person conducting antenatal sonography. So any deficiency or inaccuracy in record, whether it is in Form F or whether it is in register or any record, if it is deficiency, then under section 4 subsection 3, it will be considered as a crime and you could be in trouble. So one more area, which register is to be maintained. So this is again one more prescribed register under Rule 9 sub Rule 1, only 4 columns: serial number, name and address of patient, name of spouse or father, and date on which they first approach as far as this procedure is concerned. So with this 4 column, you have to maintain that very register. Any patient undergoing sonography, name and address and all the details should be entered in this particular register. Which are prescribed forms? There are certain forms. If your center is genetic counseling center, then Form D. For genetic laboratory, Form E. Genetic clinic and ultrasound center and imaging center, Form F. And if you have gone with Form F, then it is very clear that record to be maintained by every genetic clinic in respect of each man or woman subjected to any prenatal diagnostic procedure, technique, test shall be as specified in Form F. So you have to maintain records in Form F. But if it is invasive procedure, then for invasive procedure, this is prescribed form, that is Form G, and you have to fill up this Form G, and it should be duly signed by patient, and patient will give undertaking that risk were explained to me in language which I could understand, and it is also clear whichever specimen you collect from this invasive procedure, that very specimen you can send to registered genetic laboratory only. And at the same time, genetic laboratory is also under obligation to receive specimen from registered center only. You cannot send unregistered laboratory, or laboratory cannot receive sample from an unregistered clinic. And it shall not be necessary for genetic laboratory to obtain fresh consent if consent is already taken at genetic clinic. As far as declaration is concerned, declaration on part of patient before going for sonography that I do not want to know sex of my baby, and declaration on part of doctor who has done sonography at the end of sonography and form, he will have to give declaration that he have neither seen or disclosed sex of baby. But there are some situation in which you are allowed to disclose sex also. In sex-linked diseases or Duchenne syndrome, in this condition, you can see also and you can declare also. Form should be in duplicate. One is to be kept for office record, and second copy is to be given sent to the appropriate authority before 5th of next month of that very particular month. Submission of Form F online. In certain states, now it is compulsory to submit Form F online. So if in your state, if it is prevalent, then you have to send Form F online in prescribed time. Written consent of patient is very much must under Section 5, subsection 1B. Recommendation sheet. If patient is referred by another doctor, family physician, or any other person, that recommendation sheet is to be preserved with original copy of Form F. Many times patient directly comes to us and we advise sonography, so it becomes self-reference by gynecologist or by radiologist or by registered medical practitioner. In this situation, it is very clear that self-reference doesn't mean a client coming to a clinic and requesting for test or relative requesting test of a pregnant woman. But whenever you advise patient that sonography is needed, then also it becomes self-referral, and for that you will have to prescribe in that very case paper, and copy of that case paper is to be attached to Form F. Preservation of record. How you can preserve record? You can preserve on paper, on dictaphone, on computer, but whenever you have preserve on this electronic media, then printed copy of record shall be taken and preserved after authentication by person responsible for such record. So you will have a copy authenticated by person who is responsible to authenticate that very copy. And you will have to preserve all those records for 2 years, and in case of any litigation, till final disposal of litigation. One more situation. In case of change of employee, change of place, change of address, change of equipment install, what is the procedure? What we have to do? Because many times one sonologist is visiting our hospital, and next day he can say that I am not going to serve in your hospital. So it is change of employee, then change of place, change of address, change of equipment. If you are installing new machine, if you are selling old machine. So in this situation, at least 30 days in advance of this expected date of such change, you will have to inform appropriate authority. And this is only intimation, not permission. You have to simply intimate authority. But many a time it may happen that sonologist visiting your hospital may say that from tomorrow only I'll be not available for my services. So in this situation, as soon as you come to know that your employee or your visiting sonologist is not going to give services, please intimate appropriate authority immediately. So not to end up into any kind of problem. Who should intimate? Honor or sonologist? It is a duty of honor to intimate, but I would suggest that very sonologist who is leaving that hospital should also intimate that I am not going to give my services as a sonologist in this hospital from tomorrow only. Because in one of the cases which happened in Gujarat only, sonologist left that very hospital, but that very hospital which was run by homeopathy doctor, and he continued name of that very sonologist and filling up the forms with the name of that sonologist only. In one surprise visit by appropriate authority came to know that this type of blunder is going on in this very hospital. Though that sonologists were also served with a notice. And it was, of course, I was counseling that sonologist, but it was difficult to get rid of this problem. So sonologist should also inform appropriate authority that he is not going to give services in that very hospital from very next day. One more situation. Center is registered as a sonography center, and now you want to get it changed as a genetic clinic. What will you do? Naturally, you will have to approach appropriate authority and ask for, there are 3 conditions: fresh registration with full fees, change with difference of fees, and many a time appropriate authority is pleased and he may change merely on application, but it will be total discretion of appropriate authority when you are changing category of your clinic. As such, it is a registration of place and not person or machine. But you will have to give all the details of person working there and machines installed in that very hospital or to be installed in that very hospital. And you will give all this detail. Otherwise, place is registered, neither person nor machine. Still, many appropriate authority insist separate registration for each machine with registration fee, which is wrong interpretation on part of appropriate authority. Once place is registered, n number of machine can be installed and n number of sonologists can give their services in that very center. One more area. As far as this register at the time of registration of place, you will have to give detail of machine about make, model, manufacturer, and whether this machine is immovable or portable. So in this situation, we have to give all this information. Sale of machine. Many times we have to sell our machine. We can sell it to registered center only. And if at all we have to buy old machine from any of our colleague, then we can buy machine from registered clinic only. So it is very clear. One cannot buy, install or use sonography machine for antenatal sonography unless center is registered and detail of machine is recorded for that very center with appropriate authority. Non-use of machine. Many a time machine is out of order, and in this situation what to do? Repair. If it is repairable at clinic only, then nothing to be intimated to appropriate authority. It can be repaired in your clinic only. But if machine is to be shifted to for repair in workshop or so, then you will have to intimate appropriate authority and you will have to give all the details of vehicle also, in which vehicle, number of that very vehicle and copy of that book of that very vehicle is to be given to appropriate authority, that in this vehicle, this machine which details is with this and which is registered with our center is to be shifted to workshop for repair. Permanent non-use. Many times machine is not repairable. Then what one can do? Buy back to company. And in this situation, you will have to surrender certificate of registration to appropriate authority if you have only one machine. If you have more than one machine, and if one machine is in permanent non-use, then in this situation, you will inform appropriate authority that I am having one machine, permanent non-use, and it is non-repairable. So in this situation, appropriate authority demolish that very machine. You cannot give that machine buyback to company, or you cannot give that machine to Bangarwala. Appropriate authority should be intimated about permanent non-use, just I mentioned. You cannot give it buyback to company. You cannot, appropriate authority will demolish that very machine. How many centers one sonologist can visit in same district? So under Rule 3, Sub Rule 3, it was amendment came in 2012. You can only visit 2 clinics within district. But when this amendment came, it was challenged in different high courts, and in 5 high courts in Aurangabad, Bangalore, Chandigarh, Chhattisgarh, and Delhi. And all this high court had given a stay for execution of that order that one cannot operate in more than 2 centers in same district. And when it happened with Delhi, Delhi wrote central government, there are writ petition are challenging of this order, and all the courts have given the stay. So better you instruct your appropriate authority till final judgment of this complaint or appeal. They should not harass any doctor, and doctor can visit more than 2 centers in same district till final judgments come. Still it is stayed, and we can very well go in more than 2 places also, because it was status quo given by appropriate authority, and instruction from center is given to appropriate authority of center. There are provision of punishment also. For first instance for 3 years, and subsequent for 5 years, and fine of rupees 10,000 in first instance and 50,000 in subsequent instance. But it is for sex determination or preconceptional sex selection. But where there is no specific penalty specified, then court may order imprisonment for 3 months and fine of rupees 1,000 or both. But very dangerous provision is this: name of registered medical practitioner shall be reported by appropriate authority to State Medical Council for necessary action, including suspension of registration if charges are framed. So here word shall is used, and it becomes compulsory for appropriate authority. So whenever any complaint is lodged against any doctor and once charge is framed in court, then appropriate authority is under obligation to inform medical council of that very respective state, requesting necessary action, including suspension of registration. And many a time medical council may suspend registration for 6 months or 1 year or so. So for that very period, you are no longer a doctor. So we should be very clear in this type of situation. There are remedies also. So if at all appropriate authority goes beyond their power given to them, there are remedies also. So when we can use that remedy, if sonography machine is sealed, then what to do? Then you can have a advice from your professional colleague, that is medical advice. You can have a phone call to advocate, and you can have a legal opinion, or you can have a phone call to medical legal expert, and you could have a medical legal expert opinion. So you can prefer appeal within 30 days. Under section 21 rule 19, you can prefer appeal in 30 days. So if there is order from sub-district appropriate authority, then you can prefer appeal in district appropriate authority. If it is a district appropriate authority order, then you can prefer appeal in state appropriate authority. And same way, state government, central appropriate authority, central government, you have provision to go for appeal in this. You have judicial remedies also. So in judicial magistrate first class or metropolitan magistrate in big city, so as per the case may be, you can go in appeal in sessions court, in high court, in Supreme Court, in succession, if you are agreed with the decision of lower court. So there are two ways of meeting difficulties. You alter difficulty or you alter yourself to meet them. This gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. There are so many judgments in our favor, in favor of medical fraternity. But if you do not know, and if you do not use in your favor when you are facing any litigation, then those judgments will not be useful to you. So to conclude, if you want to sleep like this, take tender care of your patient, comply with the provision of PCPNDT Act, pray Almighty God before going to sleep, and keep my visiting card below your pillow. So be vigilant in your practice as far as PCPNDT Act is concerned, and take medical legal advice from point 1, because once you submit any document to anybody, then you cannot change. So take medical legal advice from point 1. God bless you. Have a litigation-free medical practice. With regards, salute to all. Thank you. Thank you very much. Please do not assume. Please ask if any query, any question, if time and organizers permit. Thank you. Thank you very much.
Thank you so much, sir. I think all the points for the PCPNDT Act have been very well put forward by you, and the delegates will have the very good take-home messages from this entire webinar. To extend the vote of thanks, I would first like to thank you, sir, for giving us an opportunity to coordinate and convene this on behalf of Dr. Monica Gupta, Dr. Deepika Madam, Dr. Satabdi, and Dr. Nivedita Madam. Our speakers for today, Dr. Sonal Panchal, Dr. Jaya Ma'am, Dr. Vandana Bansal, Dr. Sujit Ponkar, Dr. Suma Vishnu, for their excellent presentations. Thank you all the delegates for joining us today, and thank you Team Corona for the academic platform and the technical help that you always provide. Last but not the least, requesting you to please nominate sir. The nominations are open till 30th of May. Requesting you to please nominate sir from your society. Thank you everyone and good night.
Before we conclude, it is my humble
Yes, sir.
appeal, request
Thank you, everyone. Thank you, ma'am.
to vote and
Thank you, sir.
canvas for. Yes, Corona people, we can conclude if there is no question of from anybody. Is there any question
Yes.
in chat?
No, sir, no.
Good evening, sir.
Jaya,
I
ma'am.
wanted to
Yes.
ask something. Yeah.
Yes, madam. Welcome.
Yes, please.